computer. Okay, thank you so much for that, Brittany. Wow, okay. I guess I'll add a little thing to the side, sort of give you guys what I said earlier. Okay, right, so beginning again, right? Arteriosclerosis, arterial wall thickening, it hardens, you lose the elasticity, you get turbulent blood flow. I know that they had at the beginning, like the breakdown of everything you've learned in like term 1 over what an artery is, the components of it. They're not gonna test you on that. They're gonna use the pathologies to test you guys on that, in the sense of like, what goes wrong gets affected, right? So just know, right, arteriosclerosis, your arterial wall is hardened, right? If you have a pipe that's usually expandable, you know, it doesn't matter how turbulent the blood flow is going to get, it can expand and it could sort of minimize, right, the flow of blood. But if your arterial wall is thickened, you're not going to have that elasticity anymore. So that it's not going to be able to expand, and that's going to create increased blood flow. And that's when you're going to start to have a lot of pathologies happen, because as you know, in atherosclerosis, we can have plaques build up due to like hyperlipidemia. And then you could have an embolus and ischemia and all of that awful stuff. But I didn't like how they really did the slides. I like to start off with the easy and then I go to the harder. So Monckeberg medial calcific sclerosis, really fancy way of just saying like you have dystrophic calcification of the tunica media and the internal elastic lamina of the muscular arteries in the extremities. Now you guys are probably like, this isn't really that important, so why are we going over it? Heads up, they did ask me a question about this on the exam, and the thing that they really were asking with those on the exam was the fact that this is only really affecting the tunica media, not the intima. So you have to be really careful. In the other pathologies, it does affect the intima, because the intima is the inner layer that surrounds the lumen, right? It's the closest thing to your lumen. The minute that's affected, that actually can create turbulent blood flow, because it's cutting off how much room the blood has to move through the lumen. But in this here, right, it's sort of like the barrier, it affects sort of everything beyond the barrier of the intima. So it's squeezing on the intima, but the intima itself can still sort of expand a bit. So it's not really affected by any blood flow moving fast. You know, the intima is still able to really expand. So it's unlike atherosclerosis, right? It doesn't affect the intima. The calcification of the media keeps the lumen open. So that's going to prevent any clinically significant narrowing. So they did ask something about this. That's why I put this here. But it's really not a huge pathology. Again, you know, most of the time it's asymptomatic. We usually just end up finding it as an incidental finding. You can have it as a differential. So, you know, if you go for OSCE, and you can put it down as a differential. So usually the typical presentation, older aged individual, right? Past medical history is usually going to be like with diabetes mellitus, because that's usually what it's typically associated with, but it's also just wear and tear over time. So it could just be someone that's old, you know, you do a x-ray of them and you're going to see this pipe stream appearance. Okay, so if you see this on the exam, you should immediately just be like, oh, it has to be Monckeberg. Obviously read the question. But if you see it, you're going to immediately know that it's Monckeberg. And you should know asymptomatic, because it's not really affecting your blood flow. You're not having any turbulence, so you're not going to have any symptoms, because blood is still able to go where it needs to go. So we're going to move on from that. Next, we have your arteriolosclerosis. So right, there's the low in it. So it's telling you it's the small arteries, right? This one, I feel like it's also pretty straightforward. Okay, so these, because they're your smaller arteries, anytime that you experience any kind of turbulent blood flow or anything that can possibly cause any distension, because they're your smaller arteries, they can't really handle turbulent blood flow as much as the bigger arteries, right? Because they're so small, they can't really expand as much. So if you have any morphological changes that can affect your small arteries and your arterioles, you're probably going to have some kind of issues, right? And usually that's due to hypertension. So in arteriolosclerosis, we have hardening of the small arteries and arterioles. You can have two kinds of hypertension, as you guys know. You can have chronic and acute. Now, I know chronic, you're like, oh, it's a very long time, so obviously that's going to be the worst hypertension. Not really, right? Because if we think about it, chronic hypertension, usually, as I have down here, you guys should know the grade 1 and grade 2, the differences. Not that hard to understand. I have my little notes on the side too. My handwriting's not that great, so let me know if you need me to translate that. But they did ask a question, basically be like, is this grade 1 or grade 2 hypertension? So do like be able to differentiate between it. But, you know, chronic hypertension, if someone is constantly for years at like 140 systolic and 90 diastolic, right? 4 years, it's not that high, but it is high overall, right? So eventually your arteries are not going to be able to really handle that. And they're going to start to harden. And usually that's going to be because of hyaline arteriosclerosis, right? So you're going to have proteins below the endothelium because they're going to start leaking. Biggest thing, they're going to give you images, at least they was, oh, I see a question. There was another hypertension grade. Okay, so yeah, so if it's a path question, you want to know this. I don't think in Pharm they asked for the grading, but keep in mind though, during your small groups, I know it's just small groups, so why do I care? But during your small groups, they're very specific. So if you have a Pharm small group, you need to know the Pharm grading. If you have a path small group, you need to know the path grading. It's annoying, but that's how they are. But during the exam, I remember it just being a path question asking for the grading of the hypertension. So I went with that one. They're not too different, but I don't think they try to make it tricky. I think they were pretty straightforward with it. But yeah, I hope that answers your question. So we have on histology, right? Pink amorphous deposits, basically just hyaline within the arterial walls, right? It just looks very, very pink. Okay. What's the risk factor? Chronic hypertension, chronic diabetes, and just plain aging. So anything chronic, right? Because aging is also chronic if you think about it, because it's towards the end of life. Biggest thing, they will give you the image because they gave me the image. I'm hoping they will give you the image. The minute you see it, again, you already know what it is, right? Hyaline arteriosclerosis. Most likely they're going to ask you for the risk factor. But again, it's SGU. So whatever's on their slides, you know, but they did ask for both of these on my exam. So heads up. I have to move this down so I can read the slides. Okay. What's another thing with hyaline arteriosclerosis, right? Because it's chronic, most of the time, it doesn't actually have to be symptomatic, right? So it could be another thing where they're like, it's an incidental finding. But of course, as doctors, we're going to be concerned because over time, you consistently have chronic hypertension, you consistently have this hardening, you can have organ ischemia, and that's usually when it becomes symptomatic. So, you know, just have that in mind. So here, next we have hyperplastic arteriosclerosis. So that's that image over here. That's what we call the onion skin appearance. And this is because of malignant hypertension, AKA hypertensive emergency. We are super concerned with these, right? This is because usually it's greater than 200. So you're going to have an emergency room situation, right? Patients coming in, blood pressure super high, like past even grade 2 hypertension, super high. Most of the time, they're going to have retinopathy or even end organ damage. The biggest one to look for is the retinopathy, because that will happen because the blood vessels in your eye are much smaller than the rest of your body, right? So immediately you're going to notice that the retinopathy, and then they might come in like with other symptoms, proteinuria, stuff like that. Anything that sort of indicates that, you know, they're having some end organ damage. Okay, so it's malignant hypertension. Basically, what ends up happening is, you know, you have this huge blood pressure change in your arterioles, and then your body, the only way that that arteriole knows how to handle itself, it's like, okay, like let me make more smooth muscle cells to sort of try and contain this. But as we know, that's not really going to help because it's going to harden it, and that's going to create the blood flow to be even more turbulent. So it's a super big emergency. And they're going to give you this image here. Now, question to ask you guys, do you know the stain for this? What stain could we use that it would be positive? There's like one word on your slide, but it was asked for us. So for the hyperplastic, what did I do? Right, the PAS stain, right? Because that is staining for glycoproteins, which is found in your arterioles, or just overall in your basement membrane, right? So when you have the smooth muscle cell proliferation, you're going to have a ton more glycoproteins being produced. So that's going to stain very positively. I think it's also, you can stain it with hyaline, but I don't think it's as strong compared to hyperplastic. But yeah, they did ask for the staining for, I'm pretty sure, for the hyperplastic. So just know that. I know it was like one little thing on the slide, like in the middle of like a paragraph or something, but it was there. So just keep it in mind. Okay, next we have atherosclerosis. Okay, so this is like the biggest one, right? The most concerning one, and the one that has like the super in-depth pathology behind it, right? The pathogenesis. Okay, so I try to summarize it here, but let's just sort of walk through basically everything you should really understand for atherosclerosis. I know that they gave you a list of modifiable risk factors and non-modifiable risk factors. Now, those shouldn't be too hard to understand, right? If it's modifiable, you can fix it, right? You can do something in your life to change it to make your risk lower. Non-modifiable, you can't change it, right? It's just there. You sort of have to deal with it. Can someone give me one non-modifiable risk factor?
For genetics.
Perfect. Genetics, and yeah, just being a male usually increases your risk. And then again, family history, right? You can't change that. You're born who you are, got to deal with it. That can increase your risk. They did ask about risk factors. So be able to differentiate between it and make sure you read the question. Make sure if they're asking for modifiable, you're giving a modifiable one, right? So some modifiable ones, just walking it through, diabetes mellitus, dyslipidemia, obesity, smoking, even stress. I'm pretty sure like increased alcohol consumption, you know, those ones you really want to be concerned with. That's usually what they are more concerned with, because that's what a lot of people do. And, you know, we want to lower the risk factor. So moving on, right, with atherosclerosis, we want to do the pathogenesis of it. I think I have an image. I do. Okay, perfect. Okay. We'll go back to the other slide just so I can take a look at it again. But right, so basically, what is the pathogenesis behind atherosclerosis? You need to understand it, and I know they made it seem like a really huge big deal on the exam, like, oh, they were going to ask very nitty-gritty details, but for us it wasn't really nitty-gritty details. It was just understanding how the plaque is made, or like what's in the plaque. So that's like a really big thing to just understand. So over time, right, you have like a ton of risk factors, right? Like smoking, diabetes mellitus, all of that stuff. That's going to stress out the endothelium of your arteries. Okay. So, and then that's going to lead to, most likely you're going to have hypertension. Well, you are going to have hypertension, sorry. And then you're going to have turbulence. That's going to start to create stress on the endothelium, right? So chronic stress, inflammation, you're going to end up having endothelial dysfunction. That's going to basically mean that now your body's recognizing that your endothelium is messed up, right? Something's going wrong, it's being bothered. You're going to have your inflammatory cells. It's mainly going to be your monocytes and your lymphocytes. They're going to go through the disrupted barrier, okay? Next part, you're going to have platelets starting to stick onto the wall, right? They're going to release inflammatory mediators, right? Cytokines to say, hey, more monocytes, more lymphocytes, you know, more inflammatory cells come here. And then you're also going to have PDGF being released as well. That's going to stimulate migration and smooth muscle cell proliferation, right? In the intima. And that's going to allow for differentiation of fibroblasts into myofibroblasts. That's a big thing to understand, the PDGF. Okay, that is what is allowing for you to have the differentiation of fibroblasts into myofibroblasts, and also allowing the smooth muscle cells to proliferate in the tunica intima, right? Like I said before, when you're disrupting the intima, that's when you're going to start having your issues. So, big thing to know. Again, your macrophages are also going to come in, right? And your smooth muscle cells, and most of the time, right, you're going to have hyperlipidemia in these patients. They're going to ingest the cholesterol. They're going to oxidize the LDL, and they're going to turn it into foam cells, right? Foam cells are going to come and stick together, okay? And when they come and stick together, you're going to form fatty streaks. And I'm sure in the slides, they gave an image of that. So, you know, just sort of recognize that. Then you're going to have your macrophages, right? They consumed some cholesterol. Now they're going to be, I think they're called like lipid laden, and your smooth muscle cells, they're both going to produce an extracellular matrix. That's a big thing to understand. Your lipid-laden macrophages, your smooth muscle cells, those are producing your extracellular matrix, i.e. your collagen. And that's going to what is going to allow for the development of the plaque, right? The formation of this fibrous plaque, okay? Now that fibrous plaque is also called an atheroma, okay? Be able to understand that. And then that you're gonna have next, you're gonna have matrix metalloproteinases going to be released. That can weaken the fibrous cap of the plaque. And then you're gonna, when it weakens it, you're gonna have plaque destabilization. Eventually the plaque can rupture. We're really concerned about that because when the plaque ruptures, right, we have a ton of thrombogenic material, collagen, cytokines, inflammatory cells, everything there. It's going to sort of trigger the body to form a thrombus. And when you have a thrombus formed, it can move out into the body and occlude your distal arteries. And as a result, you can have organ ischemia, right? So I know that was a lot. Honestly, just follow their slides with it. If you like this image, feel free to use this image. I use this image. The biggest thing that they really stressed was the PDGF, understanding its purpose, and also just what actually forms the plaque, right? The atheroma. It's your macrophages, your lipid-laden macrophages, and your smooth muscle cells that are forming the plaque. So that was really the biggest thing, but hopefully that makes sense. I'm just gonna look here, see if I missed anything here that I wanna bring up. Multifact, again, of the intima, right? Manifesting at points of hemodynamic shear stress, usually due to buildup of cholesterol, arteries thickened. I think I brought up all of this. This is a big one too. It can increase the diffusion distance from the lumen to the media. I know this word diffusion distance is like a little weird. It took me like a good 10 minutes to be like, I don't even know what this is saying when I was learning this. Basically, right, your lumen to the media, right? You have the intima, media, all of that good stuff. Now that's going to be increased. Blood supplies nutrients to everything, right? So if you're increasing the distance because now you have this plaque in the way, your media is not going to get the nutrients that it needs from the blood. So that's going to also cause you issues later on because now the media is going to become weakened. But the big thing to understand is atherosclerosis is usually due to, due to multifactorial inflammatory disease of the intima. The intima is being targeted. That's why we're having issues. That's why we're going to have the end organ ischemia eventually down the line, right? So it affects your elastic arteries and your large/medium-sized muscular arteries, also why we're super concerned. So what else do we have here? Sorry, the chat is in the way. I sort of like move it. Okay. So next we have, right, the difference between a stable plaque and a vulnerable plaque. Understand that, not like too hard, but they did ask. They gave an image, I believe. I should have put it here, but I don't think I have room. But they gave two images, right, of like the cartoon image of a stable plaque and a vulnerable plaque. Sort of understand what's the difference behind them, right? A stable plaque has a ton of collagen and a thickened fibrous cap, okay? Basically, you have really thick material and then you have a tiny atheroma being blocked off from the lumen. Yes, you're still going to have turbulent blood flow, but that atheroma is super small that even if it were to burst, it wouldn't really cause that big of a thrombus because it's smaller compared to your vulnerable plaque where the fibrous cap is super thin, right? So a burst from that huge atheroma, it's going to be much easier to dislodge at any kind of hemodynamic stress. That can form a thrombus and that can occlude the lumen or even go to other parts of the body leading to ischemia. So just, they did give the two images and we're just like, which one's a vulnerable plaque, or they're like, what is composed of the vulnerable plaque? You know, so just understanding it's the thin cap with a large lipid core. That was really the biggest thing. Another thing to understand is too the vessel involvement, which ones are more highly involved. I remember, I'm trying to remember, what was it called? It was, I think he even brought it up in class, at least he did for us. I don't know if they did for you, but to try and remember it is, All right, Bruce Willis catches a perceptive criminal named Hans. Again, it's a little annoying, but again, it's going from descending to increasing frequency. So Bruce Willis is your circle of Willis, right? Catches internal carotid, a perceptive popliteal criminal coronary arteries named Hans, abdominal aorta. Obviously, if you don't like that, I understand. It took me a bit of time to really enjoy that mnemonic, but I just sort of thought of it like your biggest artery that we're really concerned with, right, is your aorta. To understand that it's the abdominal aorta, I actually have a slide depicting how you're going to understand it's the abdominal aorta in terms of this. Please write in the chat. Oh yeah, sure, I can write this in the chat. But I just sort of understood it as the aorta is the most one that we're concerned with, right? It's like it fills up your heart and everything like that. We're really concerned with that one out of all. So I remember that easily. And then coronary artery, again, your heart. So it just sort of helped me there. I don't think they really asked for the popliteals or internal or even the circle of Willis, but yeah, just sort of understanding that is good to know. Okay, hold on. I have to make sure that I write this out right. Bruce Willis catches a perceptive criminal. Perfect. Okay. Yeah, that's right. Okay. So moving on, that's pretty much all for your atherosclerosis. Next, we're going to move on to your aneurysms. So another big one, and I felt like it was also a little confusing to understand at first, but we're going to walk through it. So you can have either a true aneurysm or a false aneurysm. Can I say the arteries again? Yeah, sure. So you have the abdominal aorta being the most frequent one, right? Actually, let me go using the mnemonic. So we're going from decreasing to increasing frequency, right? Less frequent to increasing. So you're going to have your circle of Willis, so Bruce Willis, internal carotid arteries, popliteal arteries, then your heart, coronary arteries, and then your abdominal aorta. And your iliac, but they don't really focus on the iliac one. At least they didn't for us. So next we have our true aneurysm versus a false aneurysm. Really big thing to understand, right? True, it involves every part of the layers, right? The entire blood vessel wall is affected. Your intima, media, adventitia, all are intact, but they are dilated. Okay, you can have two kinds. You can have a saccular where only one side of it is dilated, or you can have fusiform where both sides are dilated. Again, I have images at the bottom here to help you understand. A false one, right, is where it looks like on ultrasound, right, if you were to just look at it, it would show dilation because it's not really like an in-depth image of the aneurysm. So on ultrasound, it would just show a dilation. So you wouldn't be able to tell on ultrasound if it's a true or a false aneurysm. You would actually have to like do a biopsy and all of that stuff to really understand, or even do an arteriogram to sort of see how the blood is flowing and seeing where the radiologic material goes through and stuff like that, right? So a false one is where the actual wall broke, right? The wall isn't intact anymore. And so the blood from the lumen is traveling through that breakage and entering the intravascular space. So it's sort of creating this here, as you can see, a hematoma, right? You're having the blood is trapped there. So again, it would look like a saccular aneurysm, the one that we have down here, right? On ultrasound, but it's not. So that's a really big thing to understand. Ultrasound, you wouldn't be able to see it. So keep that in mind. So again, true aneurysm, it involves all layers of the blood vessels, right? One wall can be attenuated or thinner, right? But it doesn't matter. The rule is the wall has to be intact and dilated. If you have even one little break, it is not a true aneurysm. What is the risk factor? Atherosclerosis, right? Really big risk factor. Again, pathophysiology, just inflammation and degeneration of the connective tissue protein. And something's not allowing that connective tissue to really be able to stay where it is at, and it's going to create a structural integrity of the wall is lost. You're gonna have widening of the vessel. Again, clinical features, it depends on which artery it is. And they're not going to give you a ton of clinical features and be like, hey, where is this aneurysm located? No, they're just going to ask you like, okay, like, what is the idea behind it? What's the risk factor? Anything from your slides is fair game, but they're not going to give you its clinical features until you figure out where it's located. Okay, so don't be scared of that. Again, false one, the layers are not intact, right? Blood is leaking out, but it's contained by extravascular connective tissue. So it's not leaking out into the body, it's just being contained. And that's why you're going to have it sort of looks like a true aneurysm on ultrasound, but it's not. Usually the risk factor for that is trauma or it's iatrogenic, right? So a failed anastomosis or graft, person just had heart surgery or any kind of cardiovascular surgery, right? Out of nowhere, they have an aneurysm, okay? That's a huge one, so keep that in mind, okay? And the question stem that also can help you figure it out. The patient coming in and they have hypercholesterolemia, a lot of the risk factors for atherosclerosis, most of the time it's going to be a true aneurysm. If they're coming in and they just, got shot, right? Start thinking false, okay? That sort of gives you an idea. So for the false on clinical features, again, if it's the trauma, right? Pain and pulsatile mass at the site of trauma. If you were to auscultate, you'd hear a bruit. This one they did bring up. It can be uncomplicated and it can be complicated. You don't even know the surgical repair part, but obviously, that's doctor, we should know that. In the complicated ones, you'd have to surgically repair it. In the uncomplicated ones, again, if it's small, you might not want to because it could create issues if you try and surgically repair something smaller. But obviously, if it's bigger than 3 centimeters, you want to repair it. So that's a really big thing. All right, so this is what I was talking about earlier in terms of, I know this confused me when I was learning because I felt like they did not explain this well. Why in atherosclerosis you have a higher chance of an abdominal aortic aneurysm, but why in hypertension you have a higher chance of an ascending aortic aneurysm? I'm going to try and do my best to explain it, but yeah, it's like I just felt like they didn't explain it well, so I'm going to try and explain it. So in atherosclerosis, right, what is the purpose of atherosclerosis? We have a weakened inner media, right? The intima is affected because you have an atheroma in the way, okay? When you have an atheroma, again, this is the increasing diffusion distance that I was talking about before, right? The blood is not going to be able to go from the lumen to and supply your inner media anymore because of the fact you have this huge barrier in the way. So the blood that was supposed to go to the inner tunica media is now affected, okay? So that is not being supplied with blood, but your outer media, right, it's unaffected because do we know where the blood supply for the outer media comes from? Anyone?
Vasa vasorum.
Perfect, right? Your vasa vasorum, your arterioles and blood vessels from your tunica adventitia, your vasa vasorum, right, supplies the outer media. So in atherosclerosis, your inner media is not getting supplied, okay? And then that's going to become ischemic, and then that's going to, because of the fact that you have the increased diffusion distance. So your inner media is affected. Now, big thing is, and this is why it's crazy, right? In atherosclerosis, it's affecting your abdominal aorta the most. Reason being that you actually, and this is like why I was able to differentiate it. You don't really have a vasa vasorum in your, what's it called? In your abdominal aorta. That is mainly located in your ascending aorta. So if you start to have atherosclerotic plaques in your abdominal aorta, the biggest thing you're going to be concerned about is the fact that now your inner media isn't getting blood supply. So people who have who have this increased risk in atherosclerosis, most of the time you see it in your abdominal aorta because the only blood supply it really has is from the lumen, okay? While in hypertension, we have in the ascending aorta, you have a vasa vasorum, okay? More than compared to the abdominal aorta. So most of the time in hypertension, because more people are hypertensive than compared to having atheromas, you're actually going to see more of an increased risk of an ascending aortic aneurysm. Because now, like you brought up before, the vasa vasorum, it gives blood supply to the outer media. Okay, and we know that in hypertension, the outer media is usually what is more affected. So I don't know if that sort of helps you guys to be able to differentiate. If you know that in the we have more vasa vasorum in your ascending aorta compared to your descending, just remember, in the vasa vasorum, that's more affected during hypertension. So if you have more of that in the ascending aorta, you have a higher increased chance of getting an ascending aortic aneurysm compared to in the abdominal aorta, you don't have that much. So you have an increased chance of an abdominal aortic aneurysm due to atherosclerosis. Does that sort of make sense? I know it was a lot and I sort of didn't. Okay. I'm getting a yes from a couple of you. Okay, perfect. So I don't know if that helps, because I know that's like sort of looks like it's just pure memorization, but if you just remember where your vasa vasorum is mainly more located, I feel like it helps you not have to memorize it as much. You can concept your way through it on the exam. All right, so I know they threw like a ton of aneurysms at you from the lecture. Knowing each one was really important because they did hit each one of these, at least for me. So, you know, I try to put the most high yield thing that I could remember on this to help you guys understand it or just remember it. And I remember on the exam, abdominal aorta, again, atherosclerosis is the risk factor for an abdominal aortic aneurysm, right? So that's going to mainly affect your abdominal aorta, usually below the renal arteries. They probably are going to give you that image that they had from class of the actual, like, you know, the actual aneurysm of it, like the real one, not like a cartoon image. Again, it could be associated with connective tissue disorders, so they could describe a Marfan's patient. I don't think they did for us. Again, typically it's asymptomatic, but if it gets too big, again, pulsatile abdominal mass, this is your abdominal aorta, right? You're gonna hear a bruit on auscultation. Syphilis, they definitely brought this one up. The biggest thing to understand, it's an inflammatory reaction to the spirochete, okay? The spirochete. Remember that. So it's aortitis in the thoracic aorta. It's during the tertiary stage. They use this really fancy word, obliterative endocarditis. They would probably describe that. They're not going to tell you it's syphilis, right? Well, they're going to give you clinical features of syphilis, but then they're going to say like obliterative endocarditis of the vasa vasorum of the aorta. So what does that tell you? If it's the vasa vasorum of the aorta, where is the aneurysm? Ascending. So your thoracic aorta, right? But the biggest thing to understand, inflammatory reaction to the spirochete. They gave us the image that they give you in class, right? The tree bark appearance. I have the part that it can cause cor bovonum because I know that's later on in the pathology. You need to know that, so just keep that in mind. And then I have a little thing here explaining that. For time's sake, I'm not going to explain the cor bovonum, but I feel like it makes sense. Obviously, if you want me to explain it towards the end, though, let me know. But yeah. So next we have the mycotic aneurysm, again, microbial infection, aorta and your cerebral vessels. Biggest one to understand, typically the middle cerebral. So keep that in mind. But again, your cerebral vessels are usually affected. Biggest thing, mushroom-shaped dilation. Okay, that was what they asked us. At least they gave you like a couple and they try to describe different ones. You have to recognize that it's a mycotic aneurysm, so it looks like a mushroom. Okay, mushroom-shaped dilation of the infected blood vessel. Usually it's due to septic emboli, again, bacterial endocarditis. It dislodges and goes out, and then that's going to cause a mushroom-shaped dilation. You're going to have congenital, right? So this one's going to definitely, you're going to have symptoms of Marfan's, you know, tall, lanky man, all of that stuff. Fibrillin 1 gene is affected. That's what we were asked. Fibrillin 1 gene. Mutation is going to cause the elastic fibers to become incompetent, increased risk for aneurysms, valve lesions, mitral valve prolapse. That's on a later one. They brought up another Marfan's. I know you learned that in the valvular section of the cardiopath. That's what was brought up. What's he's at an increased risk for? Mitral valve prolapse. So know how to identify a Marfan's patient, right? I think you guys know how to do that. We're not going to walk through it. Again, Barry aneurysm, circle of Willis. Okay, biggest one is the anterior communicating artery because of the fact that that just any junction point is where you have an increased risk for turbulent blood flow because that's sort of move through instead of going just straight, sort of to move through the junction. That's it's the anterior communicating artery. Keep that in mind. Rupture, again, rupture in the circle of Willis. You can have a subarachnoid hemorrhage, so you can have clinical features of, you know, like lethargy, they can't really answer your questions because they're sort of like their mental status is off, stuff like that. Okay, be able to recognize that. Make sure that you're not confusing it with a hypertensive emergency, right? If they are slightly hypertensive, but they're not at like greater than 200, right, systolic, that's that. If they're greater than 200 systolic, that's going to be hypertensive emergency. If they're not, try and think of, oh, what could this be? It's mainly mental symptoms, neurological symptoms. Sorry, that's what I mean. Neurological symptoms. Maybe start to think, hey, could it be circle of Willis? Could it be a Barry aneurysm? Obviously read the question. Usually it's small and saccular sheath. They did focus on that for us. Rupture is due to increase intracranial pressure. That's also something they can put in the STEM. They could be like, the person, right, worst headache of their life. Perfect, exactly. So, they're probably going to describe like, oh, like, the girlfriend brought them in after, they were, engaging in sexual activities or something like that. They just orgasmed, or even like, they were straining on the bathroom, that can increase your intracranial pressure. That could, they would definitely have something like that in there. So anything that can increase intracranial pressure. But they could also put the worst headache of their life. You have to think subarachnoid hemorrhage, circle of Willis. Perfect. Also highly associated with connective tissue disorders. So again, Marfan's patients, right? Or even autosomal dominant polykidney disease. This is something that they actually tied into the renal path. And I'll bring it back up when I do a renal recording tomorrow morning. And when you post it, you'll hear it. But they did tie that part in. So keep that in mind. All right, next we have your aortic dissection. Now, I know that they taught you both the Stanford classification and DeBakey classification. They will be specific in what they're asking in the question. I don't remember which one they asked. That I zoned that one out. But they do ask like, oh, like what is the appropriate like DeBakey classification, right? And then you have to choose that one. So you do have to understand the difference between them. So we're going to try and work through it. I just have to move the chat here. Okay, perfect. All right, 11:42. We're going good on time. Okay. So we have the Stanford classification. We have the DeBakey classification. So Stanford only has two types, right? So we have a type A dissection and a type B dissection. I feel like this one's most easiest to understand. Any dissection that involves the ascending aorta, okay? So ascending aorta means that it's close to the brachiocephalic artery. They could word it like that, right? Your brachiocephalic artery, regardless of where it is, if it's affecting your ascending aorta, it's a Stanford type A aortic dissection. If it's affecting your descending aorta, right, it's a Stanford type B. So Stanford type B cannot affect the ascending aorta. It has to be descending aorta only. So that's usually distal to the left. Here we go. Left subclavian artery. So they could word it like that too. So know the difference between these three arteries because they will try and trick you up like that with the answer choices. So usually the Stanford type, again, your ascending aorta, anything that affects the ascending aorta, like in terms of dissection, you're going to need surgery for it. Because you can have extreme complications like cardiac tamponade or even aortic regurg. So that one's the more surgical one. Anything that really affects the descending, you can usually, you don't need surgery, but you can usually give like a beta block or even vasodilators. They're not as emergent because it's your descending aorta, right? It's already past the heart. It's not going to really affect it as much, but obviously it's still important to medicate. You don't want it to get any worse. So again, Stanford A affects the ascending aorta. Stanford B begins beyond the brachiocephalic, right? Affects the descending. So you could remember Stanford B as brachiocephalic too. If you want to sort of remember it, it begins after that. That could help. Next, we have the DeBakey classification. I hate this one because it's like, we already have Stanford. And I don't even think DeBakey is really used. I think it's mainly Stanford. So I don't even know why we're going through this. So, but DeBakey, you have type 1 and type 2. Type 1 and type 2, again, they affect the ascending aorta. So they're like type A for Stanford, but both of them are just dislodged there. So type 1 and type 2 both affect the ascending aorta. Type 3 affects the descending aorta. So in type 1, what is the difference? The dissections begin in the ascending aorta and they keep going at least to the aortic arch, but they can go down the descending aorta. Okay, so it's affecting the entire width of your aorta. Obviously, right, requires surgery. Okay, like it's affecting your entire aorta, you're gonna want surgery for that. Type 2, the dissections begin in the ascending aorta, right? But they don't go past into the descending aorta. But again, it's affecting your ascending, so we need to do surgery for it. That's really the biggest thing we need to understand here, when you would want a surgical intervention and where, what kind of classification it is. That's what they focus on the exam. Okay, and then in type 3, it affects it starts in the descending and then it just goes down, right? So again, descending, not too worried about it. Usually we're just going to give medical therapy for it, right? Beta blockers and all that good stuff. So that's the classifications. If you have any questions about that, you know, just sort of try and group them in your head. I'm sure you guys will get it though. A big thing too that they did ask, it's not even in your slides, I think he said it. I had it in my, I had to write it down, and I was glad I did because they did ask this part. The dissection plane, how does it usually happen? Usually it's within middle 2/3 of the intermediate and 1/3 of the outer media. Do I understand that completely? Not really. I memorized that. I don't really know how else to do it, but it's mainly in the intermediate. Just think of it like, you know, like that one's the most affected by a dissection, and then the outer media just ends up getting dislodged too, but it's like 1/3 of it. Okay, a big thing to understand, the fact that atherosclerotic lesions tend to be protective against aortic dissections. They did ask this on the exam. It was really weirdly asked. I remember it took me like a good 3 minutes to even figure out what they wanted from me. But they did ask it. So understanding that atherosclerotic lesions, they're protective. It's because it's like a fibrotic lesion. It doesn't really allow for the dissection to keep going and cutting through because it sort of blocks off. So it's not going to allow for propagation, doesn't allow for the tear. So it can be very protective if you start to have one happening in the ascending aorta, but then you have it right before it gets any worse, right? So it's going to protect it from dissecting even more. And then so as a result, you have like a tiny dissection, not something like a DeBakey one, right? So it's good. They had this line here about the double-barreled aorta. I do remember them asking it, but it was pretty straightforward. It was like, what's the pathogenesis? Like, what's the idea behind it? Again, you have a dissection beginning, but then you have another dissection beginning at the end of it too. And it sort of like, again, keeps it in one spot. So it's allowing the blood to re-enter the lumen. Okay, so now you're having blood channeling. Do they have a picture of it here? Like if you could sort of like think of it like it's coming in here, and then out of nowhere you have another dissection happening here. So instead of going down, it's just re-entering the lumen. So then after a while, your body is going to just sort of put a lot of connective tissue proteins down, and just going to create another. It's like a false lumen. So now you have 2 lumens there, but like again, because it's sort of blocking it off, you're not really going to have that many symptoms. Again, that's not like surgically necessary either. So I hope that makes sense. Let me just look down. I talk a lot, but I need to double check that I brought up everything I wanted to. Okay, right. Like, oh yeah. Let's just go over some clinical features, right? How would you identify aortic dissection on in the question stem? Again, you're going to have a severe, they might say ripping pain. Okay, usually it could be in the anterior chest. So if it's in the anterior chest, it's going to be an ascending, right? Or in the back. So that's usually going to be descending. Okay, so that can give you sort of an idea too. You can have interscapular or retrosternal pain. Sometimes it can affect the neck and jaw. They're going to be extremely hypertensive, right? So that's a big thing to look at. Look and see how their blood pressure is. If you guys know term 4, you really need to keep in mind the blood pressure. Any vital signs they give you will help you with the question. So keep that in mind. I know in term 1 and term 2, I never looked at the vital signs. I was like, this isn't necessary. Now, really look at it. It really helps. They can have syncope. They can have confusion, stuff like that. A wide pulse pressure, you know. But usually it's going to, the tearing pain is going to be a big one. Okay, and any interscapular or retrosternal pain, that's really going to give it away. So keep that in mind. Anything else? Yeah, that's all that we really need for aortic dissections. Okay. All right, vascular ties. You guys probably hate these. I hated these just because it seemed like there was just so much behind them. but it was heavily tested. Like I was sort of shocked at how much they tested these. Like this was like a good like 15 questions. They really abuse the cardio section with vasculotides. So if you do struggle with these, obviously we're gonna go through it right now, but you know, try and like try and get a good understanding before the exam. Again, if they end up asking you guys 2 vasculotides questions, I'm sorry, they asked us like 15. So I'm just giving what I know that they gave us. Okay. The biggest thing to really understand what makes each one different. And the clinical STEM, if they tell you like it's a female or it's like an Asian child or anything like that, you know, hyper focus on that because they are trying to give it away. Okay. This is where the age and the gender and the nationality, you know, they could say, oh, like they came in and they immigrated from China like 10 years ago, you know, they want to keep this in mind, right? So big deal. The beginning parts of these. Oh. Sorry, do you have a question? Oh, okay. Your mic must have gone on mute. It's all good. So, you know, really this is the biggest thing. So again, you need to read the question in entirety. Keep this in mind, highlight it. I highlight everything when I see like, you know, a female, the age, I highlight that because it's going to be a really big deal for your guys' exams going forward. So keep it in mind. So we're going to start off with large vessel vasculitis, okay? I just try to put the like most prominent stuff on this slide, okay? Obviously follow their notes, but the biggest thing is with giant cell arteritis, or it's also called temporal arteritis, right? Usually females, greater than 50, okay? Which is going to be differentiated with your Takayasu, which is also large vessel vasculitis, where it's usually less than 50. I'm a little confused by your question. Someone asked me something in the chat. If you could just sort of reiterate what you mean. Sorry. So we have, so greater than 50 and then less than 50, okay? For Takayasu is less than 50, greater than 50 for giant cell. Keep that in mind, you know, because like that could be really like a differentiating. Obviously the clinical features are also a little different, but you know, like the minute that you see the years, you should be thinking, maybe it's this. Oh yeah, I started 11 New York time. But I am recording it. So, you know, the recording will be up. So if you want to rewatch anything that I've said, you know, that will be, I'll post it right after. The minute it gets uploaded, I'll post it and you guys can see it. Sorry, I thought I said 11 New York time. I thought that was the same thing as Grenada time now. So I don't know. But yeah, so back to giant cell, right? Associated with polymyalgia rheumatica. Big thing to understand. You're going to get someone with like pains all over their body, right? And then having these huge headaches, usually over the temples, right? Because it's your temporal artery. They might not mention the heart and temporal artery, but they may say that it's an artery is very prominent on their temple. They can say that, right? You should remember temporal artery. They will have jaw claudication, so complain of pain when they're chewing. They can have vision changes, which is a huge issue with temporal arteritis and why we're super concerned of it, because it can be from diplopia to just permanent vision loss, right? Depending on how high of a blood pressure that patient's going to have. You can just completely lose your vision. So biggest thing with that, again, associated with, okay, here we have the cell-mediated immune response to endothelial injury, right? You can have anti-endothelial antibodies. Now I write here, type 4 hypersensitivity. I know that they had like 2 slides, I remember, and they just listed stuff like type 1, type 2. You guys can sit there memorizing it, but if you understand your hypersensitivities, right, you don't have to sit there and memorize it. So type 1 is not going to be any what helpful with your vasculotides, okay? But type 2, type 3, type 4. Okay, let's go through them. Type 2. What is type 2? What differentiates type 2 from the others? I know it's like a term 3 throwback, and I know you guys just like, or threw that stuff out of your brain, but perfect. It's cell-mediated, but it's autoantibodies. Are we having any immune complex deposition in type 2? No, we are not, right? So type 2 you're having autoantibodies, cell-mediated, but there is no immune complex deposition. In type 3, you have the antibodies and you have the immune complex deposition. Okay, in type 4, you're going to have your T cells, your lymphocytes, you know, any inflammatory cells are going to become involved. That is type 4. So in giant cell arthritis, just knowing T cells are involved in the pathogenesis, immediately you should think type 4 hypersensitivity, right? And you could have these anti-endothelial antibodies, you know, they could put that in some. But for us, remember, for giant cell arthritis, they ask for the hypersensitivity. If you just understand giant cell, we can see the T cells, boom, you already got type 4 hypersensitivity in there. Okay, I know that they walk through the pathogenesis. For us, for the vasculitides, they did ask like maybe 2 questions about the actual like pathology behind it, but a lot of it was more like, what's a symptom that this patient can have, additional symptom, or, you know, what is the diagnosis, or what should we keep in mind on biopsy? Like, for example, with giant cell arthritis, the diagnostic, you have to do a temporal artery biopsy. It's just, that's the only way that you're going to be able to know if it's actually giant cell arthritis, but it is a, so Raynaud's could be for Takayasu. So I'll get into that. Thanks. I'll explain that in a little bit, but good thing you brought that up. So with diagnostics, temporal artery biopsy, you need to do a biopsy for it. It is the gold standard. But most of the time we actually, I don't think doctors really do, because again, biopsy is super invasive, right? We don't really want to. Usually this is diagnosed on clinical features, but they asked us at least, the temporal artery biopsy, knowing that skip lesions can be present. They asked for the field of the biopsy, how much do you need to really take to ensure you don't have any false negatives? I know that's in your slides. I'm pretty sure it's 3 to 5 centimeters. But whatever number they put in your slides, you know that number. Usually they're going to be like give you greater than or something like that. But you have to ensure there's no false negatives, because you can have these skip lesions. So you have to increase the field of the biopsy. Make sure you understand it, because you don't have that in the other ones. So that's a really big thing they focus on. Next, you have Takayasu arthritis, also known as aortic arch syndrome, right? Female Asians usually predominantly, less than 50. We have granulomatosis inflammation. So what kind of hypersensitivity do we think we have in this one? Anyone want to gander a guess? Type 4, perfect, guys, beautiful, right? Granulomatosis inflammation. What do you see in your granulomas? T cells, right? Immediately, type 4 hypersensitivity. Beautiful job, guys. Okay, so this is a pulseless disease, because most of the time when you take someone's pulse, right, you're doing the radial artery. In your upper extremities, you might not feel a pulse. Your lower extremities would be unaffected, but most of the time, no one's really going to take those pulses unless they, you know, the doctor has a reason to. So usually it's called the pulseless disease. When you take the person's pulse, you can't really feel it. They're going to have syncope, angina, carotid bruits. Raynaud's is a big one. This is the connection. If they didn't put it in your slides, I don't know why they didn't, but with Raynaud's, if we think about this, right, they're having a pulseless disease because it's mainly your peripheries that are getting affected, right, with Takayasu. Same thing with Buerger's, like you brought up. But in a pulseless disease, you can't feel it. So in what is Raynaud's? Raynaud's is when your fingers, or you just have like sort of like the blood supply is cut off and the fingers are turning white, right, in terms of extreme cold, for example. My brother has Raynaud's. Whenever we go skiing, his fingers are like super white. So that's what Raynaud's is. So in a pulseless disease, right, because the blood is not being pressured out, in order to feel a pulse, right, you need like a bit of pressure in your artery to be able to feel it. So people who have Takayasu, they could present with Raynaud's because of the fact that now you can't really feel the pulse. So why is it pulseless? The reason just being that it's because if you think about it, your arteries, it's in your aortic arch, right? Your aorta is the main one that's really affected with this disease. So it's granulomatous inflammation of the aorta and its branches, if we think of it. Okay, so you're going to have stenosis, thickening of your blood vessels. So most of the your radial artery, your well, I'm blanking, but like the arteries that go to your arms, they usually come from the aortic arch. Okay. So if we think about it, you're going to have bilateral brachial and radial pulses that are going to be decreased because those are coming straight from your aorta. Its major branches is from the aorta. So you're going to have a pulseless disease as a result. They're not going to, because they're so stenotic, you're not going to have that much blood pressure flowing out. Like the blood is going to be turbulent, but because they're super stenotic, you're not going to be able to feel that when you actually go and take their pulse. Does that sort of make sense? Okay, perfect. Okay, great. So yeah, that's a big one though. They're gonna be like, oh, like the radial pulse or brachial pulse not felt on palpation. Something like that is gonna be on the stem to sort of give you the fact, pulseless disease, most likely Takayasu. But you know, the biggest thing, female Asian, if they bring up a female Asian less than 50 years old, I already want you guys thinking of Takayasu, okay? That's the biggest thing. Again, diagnostics, angiography, and biopsy, you know, but they didn't really focus on the diagnostics for us because, again, it sort of presents, again, both are type 4 hypersensitivities for the large vessel vasculitis. So the histo is sort of the same. So they're not really going to ask histo for these two for you guys. They're going to ask for like the predominant symptoms or like anything special that differentiates between them. So just keep that in mind. So next we have our medium vessel vasculitis. So we have Kawasaki disease, PAN, so polyarthritis nodosa, and then Berger disease, also known as thromboangiitis obliterans. It's mainly called thromboangiitis obliterans. Berger disease is sort of an outdated term nowadays, so I don't know why they call it Berger's disease a lot. If you actually look at a lot of literature, they don't call it that anymore. So just keep it in mind if you guys are studying outside of SG resources, they're going to just call it thromboangiitis obliterans. And I like it because it sort of helps explain the pathology way better. But anyway, so I can stop ranting. Next we have Kawasaki disease. Again, Asian children, biggest thing. They're going to tell you that the parents immigrated from China or from any Asian country. And then that's going to tell you the child is Asian. Okay, biggest thing is with Kawasaki disease. It predominantly affects them like 80% more compared to other ethnicities, you know, less than 5 years old. Your coronary arteries are mainly affected. So you're going to have a lot of heart issues. And that's the biggest scare with these children because they usually die from a heart pathology as a result. You have autoantibodies to vascular antigens. Okay, and this is a big one that they really like to focus on because guess what? It's COVID-19 related. And obviously anything COVID, you know, they're going to try and relate to it because most likely our step is going to be obsessed with COVID too. Hint, hint. Yes, it is a type 2 hypersensitivity. Good job, right? Autoantibodies to vascular antigen, but there's no immune complex deposition. So it's going to be type 2. Great job. Clinical features are a big one. And I remember this one has a lot of clinical features. So guess what they like to ask you on the exam? What's an additional symptom seen in this patient? What could be seen? Or they can even ask complications because they do relate it back later on in your pathology lectures. So keep that in mind. So you're going to have erythema and edema of the hands and the feet, but that's like within the first week. So usually these patients, they're going to have a fever for 5 days and usually need a ton of symptoms to really ever be able to diagnose it because we're usually going to diagnose this based off of clinical symptoms, right? Because you're not going to take a biopsy of someone's coronary artery, right? That's very invasive and, you know, in a 5-year-old or less, that's not going to be the best idea. So it's usually clinical diagnosis that we're doing this. So usually for fever, so the parent's going to come in and be like, yeah, they had a fever maybe like 3 weeks ago. Something like that, right? And then you're going to start to see so first they're going to have the erythema and the edema happening within the first week. Then you're going to eventually have desquamation of the fingertips and toes, usually between 2 to 3 weeks. But the biggest thing, other than the presentation of the Asian children less than 5 years old, the biggest thing that they like to focus on is the strawberry tongue, also known as oropharyngeal mucositis. So the strawberry tongue is just the erythema and the swelling of the thumb. They could have cracked and red lips. Another big thing that they like to focus on, Cervical lymphadenopathy, that was like, I think the clinical feature that was an answer choice for one of my questions. It's unilateral most of the time. Okay, I think they put bilateral and unilateral. You have to know it's a unilateral most of the time. That's a big one to understand. Okay. And again, yeah, the diagnostics. Oh, they can also have a truncal rash. That's another one to pick up. But they focus on clinical features and complications. So just keep in mind complications with these children. Again, affecting the coronary artery. So coronary artery aneurysm is the biggest thing that is the focus with these patients, and it's usually what ends up killing them, unfortunately. So that's really a big thing, because any rupture or even thrombosis from the aneurysm can be like have increased mortality rates. So also yes, it mimics an MI as well. Perfect, beautiful. So that's also a complication for them. They could have an MI. I think a big one too is myocarditis or even arrhythmias. So an arrhythmia in a 5-year-old, you know, not exactly the thing we want. We don't want it in any patient, but in a 5-year-old, really lethal. So keep that in mind. Next, we have polyarthritis nodosa. So with polyarthritis nodosa, this big one is just to understand, you're going to have a patient with like a ton of symptoms. Like you can have your renals involved. You can have your, you have neurological symptoms. You could have coronary symptoms, skin symptoms, you know, like rashes on the body. You could have an MI in the patient. You could have hypertension, or even like they might even say like proteinuria or hematuria, right? Because that's going to tell you renal dysfunction. The biggest thing is though, you're not going to have lung symptoms. Okay, so if you're getting thrown with like a patient that just has a ton of stuff, they're a male. Usually it happens in young adults. The reason being it's associated highly with Hep B. We're not seeing it as much anymore because of the increased vaccination rates of Hep B, right? But usually that's why we see it more in young adults, because it's associated with Hep B. And again, it's immune complex mediated pathogenesis. So that is what kind of hypersensitivity? Type 3, perfect, right? So polyarthritis nodosa, type 3, immune complex, beautiful. So again, lungs are spared. So if you're being thrown a patient, I know it happened to me on the exam. I recognized it was a young adult, right? But they mentioned nothing with Hep B, but they threw like a ton of symptoms. They were like, the person has a rash, you know, they had an MI like a year ago. They have hypertension, all of this stuff. They recently had a stroke too. I remember it. Like it was like some crazy, like this patient was just not having a great life. But there was no lung symptoms. The lungs were completely fine. They even told you that they listened to the lungs and the lungs are fine, right? You should think of, okay, maybe polyarthritis nodosa, then look at your answer choices, okay, and see, okay, does anything here sort of tell me PAN? Go for it, because most of the time, that's most likely it. That was like the hardest vascular type question I remember. It took me a quick second to be like, what are they even asking me? Okay, so diagnostics, usually it's onco-negative, right? Because in the other ones, when you have immune complexes, usually you're going to be able to have some onco association, not with this one, right? You have to do a serology for Hep B, okay? Because most of the time that is the association, right, for this disease. So you can do a muscle biopsy, or you can do an angiography. Again, that's not, the diagnostics here weren't too crazy, other than I think one of the things was like serology for Hep B or something like that was an answer on my exam. So that's how I think I figured out this question. But you know, like the diagnostics weren't the craziest thing for this. Oh gosh, okay, the screen sharing thing is sort of taking out half the sentence for me at the bottom, so I'm going to try and figure out. So next we have thromboangiitis obliterans. So we have our Berger disease, right? Again, it is a inflammatory vascular. It's a vasculotype, right? It affects the small and medium-sized arteries as well as the veins. But we are putting it in the medium section, okay? I know they even told you, like, technically these can affect other arteries than the ones we're saying. Just know it affects the medium. You don't need to know that it affects the small ones as well. Biggest thing with this one is the smoking. That is the most important risk factor. They have to be a smoker, okay? If you have a patient that has never smoked a day in his life, you have to throw out Berger's disease immediately. They have to be a smoker. You know, and again, they can throw you the histo here because of the fact that this sort of, it's in the name, sort of what the histo is going on. thromboangiitis obliterans again, but the biggest thing that they really wanted you to focus on is the clinical features. So it has a similar presentation to just your overall peripheral artery disease, but the biggest thing is that you have a young male smoker less than age 40. Usually in your peripheral artery diseases, you're usually greater than 40. But if you have this presentation, I want you to sort of think of Berger disease. They're going to complain of Raynaud's, they're going to complain about intermittent claudication. Also, great way to know polynodosis, no ANCA, no lungs, beautiful way to know that. But they're going to complain of Raynaud's, they're going to complain of intermittent claudication. The biggest thing to understand is the smoking is the risk factor because it breaks and you have endothelial injury as a result. Tibial and radial arteries, know that one, that's why they have the Raynaud's, right? A big thing too is with these patients, I think they end up later on in life, they can have, I think it's like auto amputation of the digits because of the fact that now that the toes aren't, or just your digits, your fingertips and digits, right, are not getting blood sent to them. So after a while, they can have gangrene and ulcer, and that's why they call it auto amputation because they're just blood supplies cut off. So that's a really big one to understand as well. I hope this is helping you guys. Yeah, so this is where my slides got deleted somehow. So I don't have them all summarized as beautifully as I wanted them to here. So, okay, I'm glad it's helping you guys. So with this one, I know you guys don't really have much to read it, but I did like this slide to begin with in general that they posted. So that's what we're doing here. But the biggest thing too that they asked for this is you need to know what Palsy Immune is. I know that like during lecture, he didn't even really, I mean, for us, they brought it up, but they didn't really like seem to hyper focus on it. None of their practice questions asked about it. You know that they asked about it on the exam though, because that's just what SG likes to do. So just understand what Palsy Immune is. I can share the document if you guys want, but just keep in mind, I don't know if you were here earlier, but the most of my slides got deleted. So I had to make some like last second slides. So after this going forwards, they're probably not as pretty or as communicative, but I tried. I'll share it though if you guys want. So Palsy Immune just simply means that so these are all ANCA positive, right? The thing is there is no immune complex deposition. So if you were to do immunofluorescence like you usually would with anything that is ANCA positive, the issue is there is no immune complex deposition in these vasculitis. So you have to actually look for the antibodies on serology. So what they end up doing, I remember how they asked this question, is they gave like, I don't know which one of these they gave, but they gave the symptomology, you know, to make you think, oh, it's granulomatosis with polyangiitis, right? So you're thinking, oh, they're probably gonna ask me pathology or they're gonna ask me, you know, the ANCA type and all of that stuff. But what they actually asked was just like, how would you analyze for the ANCA? Something like that. Obviously my wording is off, but you know, I don't have the most beautiful memory, but, and then they had like immunofluorescence or they had like other like diagnostics. The biggest one was antibodies on serology. That was what they were focusing on. And I just remember reading that like the day before and I was like, oh, beautiful. Like, you know, now I knew. So, you know, watch out for that if they do ask that for you guys. Again, that's what they asked for us. So heads up. Understanding that this you would need to look for it on serology, you would not see it on immunofluorescence. That's the biggest one that they wanted you to really get. So we're going to start off with granulomatosis with polyangiitis. Because I don't really have that many notes here, I have to look at my iPad a little bit, so give me a second. Okay, so granulomatosis with polyangiitis, right? Also called Wegener's. No one calls it Wegener's anymore, so you know, I don't know why, but basically you have the C ANCA, also known as the PR3 ANCA. They really focused on the C ANCA for us and the P ANCA. They didn't really call it the other one, but it's good to know for that. Biggest thing is to really understand is the clinical features of this, because that's the only way you're really going to figure this out. This chart is great, but just understanding the clinical features overall. You know, they're going to come in with a fever. Sometimes they might come in with some weight loss, you know, like overall symptoms. That's not going to tell you anything. The first thing that they're going to most likely bring up is the fact that they're having issues with their nasal tract, right? Something like sinusitis, right? Or even like a nasal ulceration. I think a big thing is like a saddle nose deformity. Yeah, okay, yeah, that's perfect. That's in my nose. So saddle nose deformity, big thing. They can even have like an ear infection or like I think another thing is like the strawberry gingivitis, right? So it's just like anything in the nasal region, that's the biggest thing, and that's going to differentiate it from the sorry, the chat's microscopic, yes, polyangiitis, exactly, right? Both of them have polyangiitis in it, but just know that the granulomatosis one is going to affect your nasal region, while in the microscopic one, it doesn't affect the upper respiratory tract, which guess what is everything above the lungs. So your nasal region, all of that stuff, right? If it affects the lower respiratory tract, one thing to really understand, that is what's the most deadly feature in these patients, right? Usually you can't treat anything with the lower respiratory tract. So if they come in with like a cough, shortness of breath, there's coughing up blood, that's a big one. Okay, or even like pleuritic pain. Okay, that's also, so you're going to have the upper respiratory tract symptoms, the lower respiratory tract symptoms. You can also have renal symptoms, anything with the kidney. Okay, and this is the big one is this is what they call the glomerulonephritis, which is pauci-immune. Again, like I brought up before, no immune complex depositions, right? So immunofluorescence, you won't see it. You'll only be able to see if you do serology for antibodies. So again, you're going to have and this is the connection with renal, the rapidly progressive glomerulonephritis. So I think it's like RPGN or something like that, right? If you look at the urine, hematuria and red cell casts. Okay, so they do connect granulomatosis with polyangiitis to the rapidly progressive glomerulonephritis. They connected the renal to this. So it could be, but most of the time they're going to give you the sinusitis. The sinusitis is usually more prominent than the ear infection. That they could add that in there. Don't be thrown off if they add that in there, but they will give you like, you know, they're having like a runny nose, all of that stuff, the rhinitis, sinusitis, all of that stuff. Okay, they're having some inflammation in their nasal tract. That's a big one. So don't miss that. Yes, anytime. They could add ear infection, but you know, the ear infection doesn't really tell you much. You want the nasal involvement. That's the big one. You know, and then they can have a lot of other involvements that they didn't talk about in lecture. They're probably not going to bring those up. Don't get confused with those. It's really just the upper and lower respiratory tract and the kidney. You really want to look out for that and remember the connection with rapidly progressive glomerulonephritis. That's a big connection that they tied in with the renal. So keep that in mind. So hold on, I need a drink of water. I'm like, okay. So here again, PR3-ANCA or C-ANCA, right? Mainly they're going to bring up C-ANCA. It's like on serology, you should see this. Okay, the renal connection, yeah, sure. So this has a renal involvement to it, right? And when you go over your renal slides, the renal path, when they talk about rapidly progressive glomerulonephritis, I think in one of the, I know the renal slides are made like little boxes or whatever, they do bring up the fact that this is seen in people who have granulomatosis with polyangiitis. That's why RPGN is C-ANCA positive, because it's connected to the granulomatosis with polyangiitis. Anyone who has this disease is most likely going to end up, well, they are going to end up having renal involvement, and the disease is going to be the rapidly progressive glomerulonephritis. So they'll probably give you, I think it was actually a renal path question where they described rapidly progressive glomerulonephritis, RPGN. I know I keep saying that out loud, maybe that helps you guys remember it. Yeah, type 3, perfect, RPGN. They do bring it up, okay? They will bring it up and be describing it, and then they'll be like, okay, what's associated with this? Obviously, in a more confusing SGU way, they'll ask the question, but you know, they're going to ask what's associated with it. It's going to be granulomatosis with polyangiitis. I think they list like a ton of vasculitides, but you just need to know that this is the one associated. So you need to be able to recognize when it is rapidly progressive glomerulonephritis than that. Yes, it should. Yeah, it only is associated with C-ANCA from what I remember. It should be only associated with C-ANCA, right? PR3 ANCA or C-ANCA. I'm trying to think. Oh, on imaging, a big one, if they do tell you the imaging of it, you're going to have nodular lesions. Okay, so that should tell you that the lower respiratory tract is affected. Okay, right? Nodular lesions on chest X-ray in the lungs. Big one to understand. Or you can even say necrotizing granulomas. Okay, in the lung or even the upper airways, necrotizing glomerulonephritis, right? Associating that with the rapidly progressive. Anything necrotizing granulomatosis when the upper and lower respiratory tract involving the kidney, you guys should immediately think of GPA, granulomatosis with cholangitis. Okay. I'm trying to think of anything else that I'm missing here. No, I think that's it for this one, unless there's any more questions about this one. Yeah, okay. So next we have the Churg-Strauss syndrome. Again, no one really uses Churg-Strauss syndrome in medical literature anymore. They're more calling it the eosinophilic granulomatosis with polyangiitis, which obviously we enjoy more of a name because it sort of tells you already what's going on, right? When you have a necrotizing granuloma, right, with eosinophilia, okay, big one to understand. Most of the time, it involves the lungs and the skin, but it can involve your gastrointestinal tract. It can involve your kidneys. But the biggest thing is you have a ton of eosinophils. When you have a ton of eosinophils, you should really start to think of really eosinophils are associated with allergies, right? So you're going to have an allergic rhinosinusitis or sinusitis, right? So that's your upper respiratory tract. You can even have what's it called? Most of the time, the patients are going to come in and they're going to be like, I keep having these really severe asthma attacks. Okay, because again, it's associated with your eosinophils, your allergies. Okay, so they're going to come in and be like, I have some really severe asthma attacks. You know, I'm having like skin nodules. I even have the, sometimes they can even bring up kidney symptoms, right? Again, like with the glomerulonephritis, all of that. The biggest thing is though, to really tell you about this one, they're going to tell you that when they look at like, the diagnostics, like when they take a blood draw or whatever, eosinophilia, or they might even tell you there's increased IgEs. The big thing that they really wanted us to understand with this one is they try to tie it in with the ANCA type connection. Again, P-ANCA for this one, so just know that. But again, like this one is the allergy one. So I feel like this is the most easiest one to understand out of the small vessels because they're going to come in with severe allergic reactions. Immediately think Churg-Strauss / allergic granulomatosis and angiitis. And again, these are also granulomas, right? So you're going to have necrotizing granulomas in your tissues, mainly in your respiratory tract. That's a really big one. Okay, so next we're moving on to the microscopic polyangiitis. This one was, it's not hard to understand, but it was the one I didn't really understand that much. So I don't know. Yeah. This be type 1. No, because you still have the granulomas. So I know that's like a little confusing. It's not really the Ig, because in type 1, it's the eosinophils and all that that's really causing the hypersensitivity reaction with the mast cells and the B cells in type 1. This is still a granuloma, so it still should be type 4. Okay, because of the fact that you're having granulomas associated with it. But I know that is a little confusing with it, but this one should still go in type 4, I believe. Yes. Okay. So with microscopic polyangiitis, right? So I sort of compared it to the granulomatosis, so this one shouldn't take too long, right? Again, it sort of presents the same as granulomatosis, but you're not going to have any upper respiratory tract symptoms. Are they all type? They should all be type 4 because they all have granulomas associated with them. So yes, good job. Actually, no, I'm a liar. Microscopic doesn't have granulomas associated, I don't think. Oh gosh. Yeah, no, microscopic doesn't have granulomas associated with them, so it shouldn't be type 4. But I'm not remembering what this one is. This one should be, I believe you have neutrophils associated with it. So I think it's actually type 2. Okay, and Brittany's confirming it for me. Yeah, it is type 2. So yeah, that's a big one. Microscopic should not be type 4. There is no granuloma associated. The manifestations are similar to the granulomatosis with polyangiitis, like we brought up before, right? Just not the upper respiratory tract. But you don't have any granulomas. That's why there's no granuloma in the name of it, right? Notice the other ones have it. This one doesn't. So no granulomas. So that should help you guys out. So usually you're going to have the small vessels are going to are affected. Pulmonary, renal, and skin involvement, but not the upper respiratory tract. So your nasopharynx, you're not going to have any nasal ulceration, no nasal symptoms, right? So immediately when you're reading, lungs are affected, kidneys affected, even your skin is affected, right? Palpable purpura is a big one that they had in our presentation. I remember this one. That was a big one. So just recognizing that, like no nasal involvement, immediately you should think microscopic polyangiitis. If you were to do a biopsy, this is how they associate with us. Again, no granulomas. So you're mainly going to have necrosis with infiltration of neutrophils because it's a hypersensitivity type 2. Okay, and you're going to have p-onca on serology. Okay. Let me take a look at my iPad. Am I missing anything? No, I think I hit all the points for these, unless anyone has any questions. So a big thing, just understand the slight differences between them, but really understand the calcium. You don't miss that question. They asked it so weirdly on the exam, I swear. But like, if they do ask it for you guys, don't miss it, right? It's gonna be serology, not immunofluorescence for this one. Okay, so again, now we're moving on to the cardiomyopathies. I'm only really hitting the high yield. Like I told you guys, for us, the cardiovascular was mainly the first 4 lectures. I know you guys are thinking like, oh, but like the other ones are super important. They are. Study your lecture slides, but I'm only really hitting the high yield components of these, so we're gonna work with it. So in hypertrophic cardiomyopathy, their slides I felt like were awful. For this, I felt like I was so confused, and it wasn't until I even got to term 5 that I actually really understood what they were even trying to teach me at this point too. So if you guys are feeling like that, don't worry, I felt like that too. So, oh God, what happened to the chat? Here's the chat. Yeah, okay. I'm gonna put you right here. Okay. So we have hypertrophic cardiomyopathy. You can have non-obstructive and obstructive. Now, HOCM, H-O-C-M, that's the one they were obsessed with. They asked like 3 questions on it. So if you understand HOCM, like that's what, for me, like that was the one that they were really obsessed with. That's what I'm going to focus on mainly because that's what they really like. It's also like the one that the clinical presentation to sort of like come out to you, right? In HOCM, you have a genetic defect of of your, gosh, what is it? The myosin sorry, it's the myosin chain, right? Yeah, the myosin heavy chain, perfect. You have a genetic defect in it, and eventually that's going to cause like some kind of cardiac remodeling, and that's why these patients, they're usually like young, like 19 years old, and then they usually are an athlete, and they just finished a game, and out of nowhere they collapsed, right? Syncope, they just fell down, and then sometimes like 5 hours later, you find out they died. And on biopsy or like on when they cut open up the person, I'm forgetting the name of it right now. My brain's in overdrive. What are you going to see? Okay. And the biggest thing with this one is to really understand is what ends up happening is you have your septum, where is it? So we're on HOCM, right? The obstructive type. This is the biggest thing. So compared to non-obstructive, the thing is this septum here, right? In the normal people, look how small it is, right? So your blood is able to go in, go out. Here in the non-obstructive type, it's a little enlarged, but it's called non-obstructive for a reason because the blood is still able to find a way to push in. In HOCM, again, look how big the septum is. This blood really, it's going to struggle to get out. So imagine if you're working out and you need your cardiac output to be higher to get your blood to your organs, right? Because when you're working out, you're gonna have increased blood pressure. Your heart's working in overdrive. If it's not able to push this blood out, it's going to go backwards. right? And then that's what's going to cause the patient to pass out, because now the blood's not going out to the system because it can't push through here. You have a left ventricle obstruction, okay? And that's like what they really focus on here. They're going to call it like the left ventricle LVOT, left ventricle outflow tract obstruction, okay? You have an increase in your left ventricle systolic pressure. You're not going to be able to relax your ventricle as a result. You're going to have an increase in your diastolic pressure because now you can't relax, you can't fill. And as a result, you're going to have reduced cardiac output. When you have reduced cardiac output, you know, blood's not going to the brain anymore. You're going to pass out. So that's usually how these patients present with. And then you can have a ton of complications with it, like mitral regurg and all of that stuff. But the biggest thing that they really wanted you to focus on is knowing that it's a left ventricle outflow tract obstruction. That's the biggest thing. And it's the interventricular septum. They're going to try and trick you guys by saying like stuff like atrial septum, right? It's not the atrial septum, it's the ventricular septum. Okay, so like make sure that if you see septum, you don't immediately go for that answer. Make sure that it's the interventricular septum. That's really the biggest thing for this one. And they could ask about non-obstructive, but again, it's not as big of a deal as the HOCM. So yeah, so with HOCM, again, it's a myosin heavy chain. It's a genetic defect, usually autosomal dominant. You think that's going to go away? No, they're going to ask about that stuff. So that was what that was asked about this too. They wanted to know that we knew it was autosomal dominant. I know, doesn't seem important, but they asked it. So now you guys know. Where did I get this image from? Either Google or I like to use, I'm a big fan of Amboss. I don't know if anyone here uses Amboss. I love Amboss. So I learned most of my time from Amboss. So it's either from Amboss or Google, one of those. But I'll upload the slides and then you can have this image if you love it. So I'll upload it after this review. I'm trying to think of anything else. So, okay, just keep in mind too, though, with hypertrophic cardiomyopathy, the biggest thing is, this is where I found the way that they taught this to be confusing. Hypertrophic cardiomyopathy is associated with concentric hypertrophy, okay? The minute you hear concentric hypertrophy, you guys need to know that means that it's going to be a hypertrophic cardiomyopathy. I remember when they taught this in term 4, I remember the first slide, like the overview of cardiomyopathy or whatever, that lecture that was just random. They had concentric and eccentric next to each other. And then when they taught about hypertrophic, they didn't make that connection, which I thought was stupid because this is the connection behind it. It is concentric hypertrophy, okay? You have parallel sarcomeres being added, and that's what leads to the thickening of the ventricular wall. This is because of parallel duplication of sarcomeres. So concentric hypertrophy, I immediately want you guys to think hypertrophic. And when you think concentric, you need to know that's diastolic dysfunction, okay? What is diastolic dysfunction? When the left ventricle is unable to relax and fill. Okay, big thing to understand. Diastolic dysfunction, you can't fill it up. Okay, that's the biggest thing with concentric hypertrophy / hypertrophic cardiomyopathy. So understanding that connection, it like wasn't that, they did ask about concentric hypertrophy and what it is and all that stuff. They didn't connect it with hypertrophic cardiomyopathy in the questions, but they do in term 5. The CPRH exam I took, that was very much connected. So I'm saying it now, you know, like try and learn it like that. Hopefully that helps. And then, oh, another thing is I've had someone message me before. You don't need to know about the whole like, this exam is going to be pathology. You learn physiology in term 1. There's not going to be a lot of physio behind it. They're not going to ask about, oh, will you have increased afterload? Will you have, you know, like the fancy words like afterload, preload, all of that stuff. They're not really going to ask about that. But in term 5, they do. So, you know, if you walk through it in your head and just sort of try and connect the physio, just so it's easier when you have to review all of this stuff in term 5, you know, but they're not going to ask you about increased afterload. They're just going to ask you about concentric hypertrophy, you know, the asymmetrical septal involvement, interventricular septum, stuff like that, you know, like buzzwords was a really big thing for these kinds of stuff on the exam. So let's go over how, again, the patient would present against syncope. The biggest thing to know, and this is what they ask, what is the biggest complication of this, of HOCM? Does anyone know? It's sort of like intuitive, but what are we the most scared of with these patients? Perfect. Sudden, oh, okay. Sudden cardiac death. Beautiful. That's the biggest thing, right? And that's what a lot of patients just die from. They, you know, after intense physical activity, they just unfortunately die. So that's the biggest thing. Sudden cardiac death. Know that association. That was definitely a question for us. Also knowing another association, you could have a systolic ejection murmur. Even with hypertrophic cardiomyopathy, know that you have an S4 gallop. With dilated cardiomyopathy, which is like the different, and I'll go walk through that, that's an S3 gallop, but I'm saying it now. So hypertrophic cardiomyopathy, concentric hypertrophy, diastolic dysfunction, S4 gallop. When you hear a hypertrophic cardiomyopathy, you should remember all of those other three things. Understanding those other three things is really going to just help you understand the pathogenesis without having to think too hard about it, right? So interventricular septal involvement, and remember it's the myosin heavy chain. Big thing to understand. Okay, no questions on that. We're going to move on to dilated cardiomyopathy. Degradation or duplicate. Could you sort of explain what you mean by that? Like of the chain? From what I understand about that, it's autosomal dom. I think it's the reason why the sarcomeres end up going in parallel and why you have concentric hypertrophy. The fibers just aren't able to arrange themselves in the normal way. Now they're arranging themselves parallel, and that's what ends up getting the concentric hypertrophy. I'm pretty sure that was with the myosin heavy chain. I'd have to double check for you, but they didn't really ask anything about that. I just know they asked about autosomal dominant, but they didn't really ask like what ends up going wrong with it, if that makes sense. I'm sorry if that's not that helpful of an answer. That's how I do it. All right, let me just take a sip of water. Okay, really going for this. Okay, so with the hypertrophic cardiomyopathy, they really HOCM, the obstructive one, the genetic part of it was the big thing. That was the etiology, right? Whatever you want to call that word. That was it. Etiology for dilated, you could have so much. You could have a genetic association with it, but they didn't really ask the genetic for this one. So just letting you guys know for us. Or you could have secondary causes. And usually the secondary cause was the biggest thing for these, just understanding that like so many things can lead to dilated cardiomyopathy was a big one. That's why I had to write here due to various causative factors, because it's a lot. Coronary heart disease, one of them. Hypertension can lead to it. Your infections, really big one. Understanding the connection with like Coxsackie B. Yeah, Coxsackie B myocarditis could lead to dilated cardiomyopathy. HIV can lead to dilated cardiomyopathy. Even rheumatic heart disease, right? That could give you dilated cardiomyopathy. And I think there was one more infection. Let me take a look. Yeah, Chagas disease. There we go. That could also lead to dilated cardiomyopathy. So that was a big one. But one that I remember them testing was the alcohol use disorder. Alcohol just in general, that's a big one. You're gonna have an alcoholic, most likely, if they look at their heart, they're most likely gonna have like a dilated cardiomyopathy. I don't know how else to say it. You could even have it like with certain drugs. I think like cocaine was one that was mentioned in your slides. And this is with a farm connection, right? Good. Okay, yes, farm connection. Does anyone know what drug has a can cause dilated cardiomyopathy? I know it's farm, so.
Doxorubicin.
Perfect. Yes, doxorubicin or Rubicon. Yes, perfect. That was a farm connection. It's definitely something you guys should know for the exam. Huge adverse effect. So keep that in mind. Dilated cardiomyopathy, doxorubicin. I'm trying to think of any other, but as you guys can tell, dilated cardiomyopathy, tons of various causative factors. Just sort of walk yourself through them. I know they have them listed on a slide. Just try and remember them. Any of your valves going wrong, like your valvular heart diseases, any of them can cause dilated cardiomyopathy. So understanding that too was a big one. So again, anything that can cause this, right, would decrease your myocardial contractility, right? If you have a decrease in your myocardial contractility, your body is going to recognize this, and it's going to be like, okay, like if you decrease your okay, so if your heart is not being able to contract as much, your cardiac output is going to get lower, right? Because you're not going to have as much blood being pumped out. Your body doesn't like that. So it's going to try to do anything to maintain your cardiac output. And that's why this ends up getting dilated. You're going to have a lot of volume left over in your heart because of the fact that now it's not being pumped out as much, right? You're going back to basic anatomy. Again, you guys don't need to know the fancy words like preload, afterload, any of that stuff. But if you guys, well, you need to understand it for step. But like in general, if you're not that strong in it, they're not going to ask you like this on the exam. But for term 5, you need to know it. So if you need help, let me know. So the blood is going to go in, right? But your heart is unable to contract as well. So as blood is going in, it's not pushing out all that blood. So you're going to have an increase in your end diastolic volume, right? At the end of diastole, as your heart's trying to contract, you're going to have more volume in your heart. Your body's going to recognize that you're having way more volume there than you need. So it knows that it's going to have to do something to help the cardiac output. You need more blood to be shuttled out because you have more left in the chamber at the end. So you're going to have something called, the big word that they're going to tell you is myocardial remodeling. Basically a fancy way of saying we're going to find a way to make this heart work a little bit better, right? So the way that they do that is going to be something called eccentric hypertrophy. So dilated cardiomyopathy has eccentric hypertrophy, guys. So that's when your sarcomeres are added in series. And when they're added in series, that ends up giving you dilation of the ventricle. That's why it's called dilated cardiomyopathy. But, your heart is thinking, oh, if I do this, that's going to help. It's not. It's actually going to reduce the ability for the contractility, because look, all that muscle that you had before to help contract, it's gone now, right? Now this cardiac remodeling actually stiffened your ventricle. So now your contractility is going to be reduced again. You're going to end up having systolic dysfunction, right? Because you're not able to contract. And as a result, you're going to have less cardiac output being given, eventually leading to heart failure. Big thing here is the heart failure, okay? So dilated cardiomyopathy, you need to know the association with eccentric hypertrophy, which is just when sarcomeres are added in series. And this is systolic dysfunction. You see how it's the opposite of hypertrophic cardiomyopathy, right? So just be able to make that association because they do ask stuff like that on the exam. Again, so to really understand this, usually with these, you end up having left heart failure first, right? But eventually, if this isn't, eventually these patients are going to end up having right heart failure, and this is usually why they pass. Because if you think about it, now your contractility is not, it's not working, right? You're having systolic dysfunction. You're not able to contract to push out that blood. You're having a ton of blood in the left ventricle now. Well, eventually, your left ventricle is not going to be able to hold as much blood anymore, and that's going to start going backwards. So in left heart failure, right, now you're really not being able to push out that blood. Now it's going to start going backwards. It's going to go into your pulmonary system, right? Because blood comes from the pulmonary system into your left side of your heart. So now it's going to go backwards. You're going to start to have a patient with dyspnea, with, they're not able to breathe. When you listen, when you auscultate, you're going to hear like fluid in the lungs. Stuff like that is going to start to tell you that they're having pulmonary congestion. That's a big thing that they wanted us to associate with dilated cardiomyopathy, pulmonary congestion, right? And eventually, when your pulmonary system gets overflown, that's the right word, it's going to go back into your right heart, right? Because your pressure systems are going to change. You're no longer going to have the right to left. Now it's going to go backwards, and now your right heart is going to start failing. And that's when you might start to see like you know, like symptoms of right-sided heart failure, like the increased JVD, even like if it goes back to like all the way to your liver, hepatojugular reflux, stuff like that. You know, you're going to start to have like more liver failure, peripheral edema, stuff like that. Okay. This is associated with your S3 gallop. So I'm glad you asked me that. This is S3. So if they also say an S3 gallop, you got to start thinking dilated cardiomyopathy. So again, those like buzzwords really help with these symptoms. So again, because of the fact that it really depends on what stage of heart failure you're at. If you're at left heart failure or right heart failure, the symptoms are sort of like a little bit broad, but they also tell you what stage you're at. So right, if you have exertional dyspnea, isn't the left ventricle on the other side of the image? Actually, yeah, now that you bring that up, yeah, but okay, so maybe this wasn't the best image to do. The left ventricle is what ends up getting dilated. I guess in this patient, they had also right heart failure, so maybe that's why, because eventually your right, when you start to have right heart failure, your right ventricle is also going to get dilated. So maybe this wasn't the best image. I just sort of saw that it compared the two, which is why I pasted it. Again, my slides got deleted. So this was very last second of me trying to fix and have something for you guys to read and look at. But yeah, so it's the left heart gets affected first, the left ventricle will get dilated first. Then if you consistently go to right heart failure, then your right ventricle is going to get dilated. And your symptoms, again, your symptoms sort of tell you at what stage of heart failure you're at. You're like your left heart failure and your right heart failure, and I did give you some of those symptoms. But again, unless they're focusing on a heart failure question, the dilated cardiomyopathy is really going to be more focused on the fact that like basically the pathomechanism we just talked about, right? The eccentric hypertrophy, the ventricle is dilated, you know, compared to hypertrophic cardiomyopathy, you have the thickening of the interventricular septum because that's a concentric hypertrophy. Stuff like that is really what they focused on. So yeah, is there anything else that I want to bring up here? No, I think I hit all the points that I want with this. So yeah, I know for us, they didn't really connect the like concentric, eccentric to like the right things, but just know concentric is hypertrophic, dilated is eccentric, and understanding what each one means really helps you out on the exam. Okay. Okay, 1247. Okay, I really want to start doing questions. So let's go through MI, and then I think, yeah, that's all I was able really to fix before. But I have like the questions I have also test other concepts I didn't review yet. But like my idea was I'll review them as we're doing questions, so that should help. Okay, so this is from your first aid, obviously. You need to understand the pathology behind MI. Knowing the time, really important. And like what you see in the histo, really important. I know that this is a cartoon histo. They did put the histo from your slide. It's exactly from your slides. I think one of them was upside down. So obviously, SU is annoying like that. But you know, like look at the histo and understand it. Is a really big thing, and I wanted to put the pictures of that, but you guys already have them in the slides, so I figured this would be just easier for me because, you know, slides got deleted. Okay, so let's go over what an MI is. Okay, so let's start off with like really just let's go off with the clinical features at first, right? Because I know like some people are like, oh, like, okay, how about this? Can someone tell me how do I differentiate between an MI and just like normal angina? It's normal chest pain. How would I start thinking MI? Okay, cardiac enzymes, good. Biomarkers, okay, good. But how about in terms of time?
Usually it's more than 20 minutes, I think.
Perfect, right, 20, 30 minutes, but it's usually much longer compared to just normal angina, right? Angina, if they're like, oh, like the pain was only there for like a minute or two, you know, that's not gonna be an MI. MI is gonna be a retrosternal chest pain, right? Like chest pain, oh, that's what retrosternal means, sorry. For longer than 30 minutes, basically. You're gonna get the whole like, you know, it's radiating to the shoulder. That's a big one. They could say to the left arm or anything like that. But any radiation to the left side, that should tell you it's an MI. You know, they'll have shortness of breath. You know, they may look pale. They might be nauseous, vomiting. Like, think of it. If you're in a really severe pain, right, you're going to look nauseous, pale, all of that stuff. But really, the biggest thing is to understand that the timeline of the pain is really what's going to make you think, okay, this has to be an MI. Okay. You could have symptoms of even like congestive heart failure, depending on if this person has other pathologies associated with it, right? Or you could even have like, I'm trying to think, or they could be in cardiogenic shock. That's what I mean. Sorry. So like they could be hypotensive, they could be tachycardic, all of that stuff. But the biggest thing is, again, chest pain with a time. They can even give you biomarkers, right? If they don't give you a time, but you see that the troponins are high, you know it's going to be an MI, right? So what is like really, what causes an MI? Well, you're going to have coronary artery occlusion, right? So your coronary arteries are the ones that surround your heart wall. So the minute that they become occluded, your heart's not getting the blood that it needs, not getting the nutrients. Those cells, they start to die. They're not going to be able to pump out as much blood. As a result, you're going to have a very decreased cardiac output. That's what causes the pain, because your organs are becoming ischemic, essentially, in a way, right? But it's only within 30 minutes before the occlusion goes away. You can either have a partial occlusion or a complete occlusion. Again, I know they brought this up. Usually, if it's a complete occlusion, that's going to affect the entire myocardium, like the entire, I think they say thickness of it. So it's usually a transmural infarction. So understand, if it's a complete occlusion, usually it's transmural. And then if it's a partial one, I believe they say it's only affecting the inner part of the myocardium. So that's the subendocardial infarction. So I know they had like an image of that, like just a ton of like coronary artery occlusions. They asked us about the transmural one, but obviously they can choose whichever one they want. So understanding that, you know, it sort of like makes a little sense. Usually partial ones is an NSTEMI, and usually the complete ones are a STEMI. Again, should make sense too. You are not going to be given an EKG and asked to interpret it. So don't be worried about that. They will just tell you if what they see on EKG, like a STEMI or not. You will see EKGs for the farm drugs though, and I was going to bring that up later, but just know that. Sorry, that's my dog, if my dog bothers you. But the antiarrhythmics, huge thing with the farm. EKGs, being able to understand it. I'll go over that in the video I make, but that was a big one. And it threw me off because there was like 10 of those. And I was like, oh, okay, great, more EKGs to look at. But not for PATH. No EKGs for PATH. That's what I want to say with this. Again, usually these are due to atherosclerosis, right? Plaques. So big thing, them getting lodged in the blood supply getting cut off. So big thing. We're going to go into the pathology because that's what they focused on, and you need to understand the pathology behind it. Okay, so we're going to start off with 0 to 24 hours. Okay, one thing I don't like about this is they don't have the what you see within 0 to 4 hours, and I know your slides have this. Within 0 to 4 hours, right, you're going to have the hypercontraction of the myofibrils. You're going to see wavy fibers. That's seen within the first 4 hours of MI, okay? That was asked on my term 5 exam. I don't know if they asked it on your guys' exam, but you know, just letting you guys know, in term 5 they asked that. So wavy fibers are seen within the first 4 hours. Then you start to have your early coagulative necrosis set in. Sort of makes sense, right? When when your cells are not getting the blood supply, right? They're not immediately going to call in their inflammatory cells and be like, hey, like, you know, come and try and fix me. That's what inflammatory cells are trying to do, right? You're going to have the myofibrils, because now you're the wavy fibers, sorry, because your myofibrils are getting distorted because they're not getting the nutrients. But then after a while, your cells are like, okay, you know, clearly something's going wrong. That's where you're going to have the coagulative necrosis. That's when you're going to have the those cells start to release inflammatory cytokines to try and have your inflammatory cells come in. That's how you're going to have some edema, some hemorrhage, like what they brought up here. See, they put wavy fibers, but that's mainly in the first 4 hours. So just keep that in mind. You're going to have your neutrophils come in. That's the biggest thing with the 0 to 24 hours, right? Neutrophils, huge thing. They are going to come in during your first 24 hours. You can even have contraction band necrosis. That one, though, is usually due to reperfusion injury. Okay, so knowing that is really important. That's usually because you're going to have the release of the ROS. What does that stand for? Reactive oxygen species. That's going to cause calcium to flux into the myocytes. That's going to cause a contraction. So if you see contraction band necrosis, just know that's because of the ROS, the reactive oxygen species. Ugh. Sorry, I need another drink of water. Okay. So usually that's within 0 to 12 hours. Usually that's within 0 to 24 hours. But you're not really going to be able to see this macroscopically, right, until 12 to 24 hours, where you start to see something called like dark mottling. I don't know if that's in your guys' notes. I don't know. That's probably not that important, but just letting you guys know, like macroscopically, you won't really see anything until like 24 hours in. Microscopically though, remember, first 4 hours, wavy fibers. Everything after that until 24 hours, you have the early coagulative necrosis, neutrophils. Just think neutrophils. Unless they talk about reperfusion injury, then you want to think about the reactive oxygen species. Okay. They also have their complications. Again, I sort of brought this up earlier. Heart failure, right? Cardiogenic shock, ventricular arrhythmia, you know, just think of it within the first few moments of these symptoms, you're going to have the huge things. It has coagulative necrosis of 6 to 12. Next bullet point states why wavy fibers present. Okay, so again, SGU likes to have their own things with how they like to do it. So maybe I should go through your guys' slides instead of going through this thing. Actually, yeah, let me pull up the MI slides for that so I don't confuse you guys. In the, what's it called? In your term 5 exam, though, you're going to want to learn how like every other resource is teaching you. So let me just, you cannot minimize Dune when you are recording this meeting. Oh, okay. Can I just do? Oh, what lecture was that? That was that your guys' 5th lecture? No, that was in 7th lecture? When did I teach you guys MI?
The 5th lecture.
The 5th one? Okay. Oh, let me pull this up. And then we're going to do some questions, guys. I'm going to try and go through myocardial infarction because like I feel like this one's a more easier one to understand. Yeah, these are my notes. So let me see. Share screen. Ignore all the tabs. I know everyone always says I have a ton of tabs, and I know I do, but you know, I need them. I don't know why, but I need them. Okay, so right. So here they're saying 6 to 12 hours. Honestly, it's more like 0 to 24, but you know, 6 to 12 hours for your exam. Okay, you can even have this vacuolization, which is just where, again, this sort of has to do with like calcium and all of that stuff, but they're going to say salt and water within the sarcoplasmic reticulum. So the myocytes are vital, but they can't contract. And that's why you start to have like issues with your heart after a while, and why people with MIs tend to have consistent MIs or even like heart failure down the line, because now your myocytes are not as contractible as usual. And so they can end up getting dilated cardiomyopathy, right? Boom, connection there. So keep that stuff in mind. Next, so after, what else is here saying? Yeah, dense polymorphonuclear leukocyte infiltrate in an acute MI that is 1 to 3 days old is over here in the image. Again, you're going to have continuously have your coagulative necrosis. So now you're going to have your monocytes come in, but a lot of it is just the neutrophils. Okay, so you're just going to have extensive inflammation. Okay. Next, after about 3 to, they say here's 3 to 7 days. Okay, 3 to 7 days, we'll go with that. Neutrophils are going to start being replaced by macrophages. Why? Neutrophils are in your acute inflammation, right? Macrophages in your chronic inflammation. After 3 days, you know, like that's going to be considered some pretty chronic stuff. So macrophages are going to come in. What do macrophages try to do? They try to lay down granulation tissue, right? You're going to have your lymphocytes, all that. But the biggest thing here that they want you to know is macrophages. They're going to try and come in and eat up everything that was necrotic, right? Your myocytes that are dead, they want to get rid of it because now that's not supposed to be there, right? So your macrophages are going to try and clean everything up. You're going to have your granulation tissue, your dense collagenous scar, right? And that's why we can see this usually on a, oh gosh, I can't remember the imaging, but you're going to be able to see like a dense scar. And that's what's going to tell you that this person had a previous MI, right? Stuff like that. Understanding the pathology, they're going to show you these images. I think it was this one that was upside down. And at first I was like, but then again, this looks like what it does, right? This one looks like it's hypertrophy of the cells. So even being upside down doesn't really change much, but they did flip it for us. So just letting you guys know. So here, yes, perfect. Oh, so they do have the dark modeling. Nice. Oh, no, why is the chat getting bigger? Oh, I just want to put you to the side. Okay. So again, 0 to 12 hours, dark modeling. Gross just means macroscopically. So if they say macroscopically, don't, right? Gross means macroscopic. Histology means microscopic. Just know that. What we see on a bigger scale, what we see tiny within cells, right? So you have dark modeling, wavy fibers, early coagulative necrosis. Again, we still have the dark modeling, right? Early neutrophilic infiltrate within 24 hours. Modeling, but now it's more yellow, heavy neutrophilic infiltrate, okay? So again, during acute inflammation, neutrophils, really thing to understand. It's more of an immuno thing, right? 3 to 7 days, hyperemic border was a big thing, hyperemia. Which, you know, hyperemia just simply means like you have an increase in blood flow to that part of the body, right? Because you're trying to fix that area. That's why we're sending you these macrophages in to try and fix everything, to eat up the necrotic tissue. So your macrophages are involved when you have hyperemia. So keep that in mind. Maximum softening, that just means like no myocytes, no collagen. So granulation tissue is being laid down. After a while, you're going to have collagen deposition. Collagen tends to be more gray. So you're going to have grayish of the infarct beginning. You have remodeling. Eventually, you're going to have scarring after 2 months, and you're going to have a dense collagenous scar. And that will tell you if the person had a previous MI. So again, that's going to be more grayish white. So they can use these kinds of words to describe things, but just understanding acute inflammation versus chronic inflammation, what you see is a really helpful thing. But they also give you the histo. So know your histo, and you should be able to figure out the MI questions. And that's about it that I had from my slides. But I want to do questions with you guys. Okay, we have like 30 more minutes. Maybe I can convince my dad to let me go to 140. That should be enough for the questions. So let me pull up the questions. Okay, hold on. How do they? Where did I put them? No, I don't want this anymore. Okay. Slideshow. Oh gosh, how do I do this? Share screen, share, slideshow. Okay. So we'll do it like an IMCQ, 72 seconds. Or and obviously put in the chat. You could personally message me, or you could just, you know, don't even have to, just put it to everyone. Whatever works for you, you know, anything works. Okay, I have a good amount of you that have answered. I'll give like 10 more seconds. Good amount of you have answered, and you all are right. So giving you guys confidence. And then if anyone is feeling brave and they want to explain this one, you know, sort of see like where you guys are at, you guys can feel free. Otherwise, I will walk through it. But you know, if anyone wants to give it a shot at explaining why they think this is the answer, which everyone who messaged me got it right. So, you know, if any of you want to explain it, go ahead.
Right now?
Yeah, sure, go ahead.
Okay. I thought this was giant cell vasculitis, arteritis,
Yep.
because first of all, she's 74, she's a woman. And then the main things that stuck out to me were that, what was it? There was pain in her jaw, and then she had the headaches and the pain in the jaw for the chewing. That was like the main things that stuck out to me. And then the blindness and the diplopia, the ocular changes are like the other symptoms.
Perfect, exactly, right? So perfect. So I also broke them down for you guys, right? So this is giant cell arteritis, exactly like how Rochelle, I hope I'm saying your name right, walked it through. But can anyone tell me what the 5-month history was trying to hint at by any chance? What is giant cell arteritis usually associated with? What other disease? We know? I know it was like in your slides, it was like a one-liner at the bottom of the page.
Would it be poly something myelitis?
Okay, so I know.
Rheumatica.
Perfect, exactly. Polymyalgia rheumatica. So that's how polymyalgia rheumatica tends to, how they're going to try and describe it on exam. Increasing stiffness, muscle pain, weakness in shoulders or legs, just overall weakness, right? You know, and then again, like Rochelle brought up before, the fact that she's a woman, the fact that she's on the older side of age, right? The jaw pain when she's chewing, so jaw claudication, right? The temporal headaches, or just the headaches in general, right? Left-sided headaches, right? So a big thing, okay? That should immediately start to scream out to you guys, giant cell arteritis. And a big symptom that we are very concerned as with doctors, right, is the fact that they can go blind. So ocular symptoms ranging from diplopia to blindness, GCA. The other one's like Takayasu, right? That's the pulseless disease is what B is saying. C again, Takayasu or Berger's, like you guys brought up. I just didn't put the Berger's thing, but yes, Raynaud's phenomenon is also with Berger's. And then oropharyngeal mucositis is the strawberry tongue, right? Seen in Kawasaki, seen in young Asian children. So that obviously does not fit this presentation. So it's obviously A. Good job, guys. Also, this image I definitely stole from Amboss. So if you guys wanted the association with this, again, I'll upload the questions anyway for you guys to do if you guys want to do them at home. Yeah. All right, let's give this one a shot. I obviously stole this question, but I put my own answer choices here. So give this one a shot. Yeah, it looks like everyone in the chat, you guys are too smart. You guys all got it. So I'm going to give like 10 more seconds for anyone who is still reading the question. And then if anyone else wants to give this one a shot, I feel like this one would maybe a little bit easier, but this is, again, you're either going to get, like you have to identify a symptom or even like something with biopsy, that's mainly with giant cell, and then, or even just a diagnosis one. It's really what you're going to see with the vasculitides. So these are the kinds of questions you guys are going to get. So if anyone wants to explain this one or why they chose their answer, what's prominent in the symptomology.
So the first thing for me is his age. It's a 5-year-old kid. After that, his vitals, he's got a fever. And then he's got this tongue and pharynx that are red. So I was thinking like strawberry tongue. And then he's got the unilateral cervical lymphadenopathy.
Mhm.
And then those are the things that I remember from the list that stuck out to me. So that's why I picked Kawasaki. I knew it wasn't Burgers because I'd be expecting a male in his 40s with some kind of smoking history. I knew it wasn't Sherg Strauss, expecting some sort of respiratory situation, like an asthma or something. And then I knew it wasn't polyarthritis nodosa because you would expect like hypertension and some other like systemic issues, which this kid doesn't have.
Perfect, exactly. Beautiful explanation. So I know I said young Asian children, right? High association with Asian children, but it doesn't have to just be Asian children. But you know, I didn't state, or like this question doesn't state, sorry, that the child is Asian, but every other part of the symptomology, right, is presented here. So just like exactly what Brittany said, right? We have the high-grade fever, we have the rash on the trunk, and specifically later on they tell you it's a macular rash, huge buzzword. The tongue and pharynx are erythematosus. That's telling you that most likely strawberry tongue. On the exam, I remember them actually like describing more like red and stuff like that. But just in general, like, you know, like the symptomology should really just point you guys towards Kawasaki. So great job explaining this. So yeah, Kawasaki. All right, let's try this one out. This one's a little bit, the answer choices are long, so I know it's going to take a little bit longer. Okay, so a couple of you have messaged me, a couple haven't. I knew this one was going to be the one that's going to throw you all off because you know, it's a lot of words and you really have to think about it. Two of you got this one right. I'm just going to say the answer is B. Okay, and we'll walk through it. But for the people who did choose B, if you want to say why you chose B, like what about the presentation made you choose B? But if you guys don't want to speak, it's also okay. I can also walk through it.
I saw that it's a 38-year-old man. He has a smoking history, and it kind of looked like he had Raynaud's, and so I went to Burgers.
Perfect. It is Burgers. Great job. So the first thing first, whenever you're reading clinical vignette, okay, I'm just gonna give the. Can you guys still hear me, or do you guys want me to speak louder? Or
I can hear.
okay, you guys can hear. Okay, I'll try and speak really loud. I know the neighbor behind me is really loud. But so basically, first things first, right? He has a painful rash affecting his left foot. For the past 2 years, recurrent episodes of color changes in his fingers when exposed to cold. What you said before, that is Raynaud's, right? Any color changes, usually it's going to be like pale white. They first turn white, then they can progress to blue and red before they randomly resolve. So, you know, they didn't think it was that big of a deal. He smokes 2 packs of cigarettes daily for 20 years. There's your smoker, right? Male smoker with Raynaud's. I immediately want you to think of burgers. If the painful rash affecting your left foot threw you guys off, that's actually because this is late. It's like a late manifestation of burgers. Remember when I brought up the whole like ulceration of the digits, the auto amputation, that this is sort of like what they're trying to lean at for without specifically saying it. So it's a painful rash affecting his left foot. Physical exam shows purple nodules. Again, that's the superficial thromboelphiditis. I can't say that word, but it was in my lecture notes and it's in your lecture slides. And then they go along the course of the lateral marginal vein. So any nodules that go along a vein, that's what superficial thromboelphiditis. That's also another association with burgers. Obviously, Raynaud's phenomenon is more easier to look at though. Dry ulcers in the tip of his right index finger and the distal aspect of his right calyx toe. Basically biopsy of the dorsal pedis artery, right? So we already figured it's for burgers. We know it's mainly going to be your lower extremities, your upper extremities, arteries, sorry, tibial and radial, I believe, but this one's dorsal pedis. Again, anything that affects your medium vessels will show which of the following findings. So now you really have to like walk through each of these and be like, okay, which one is which? So congrats to everyone who figured out B is burgers. So segmental thrombosing inflammation with sparing of the internal elastic lamina. That is burgers right there. And they will word it something similar like this on your guys' exam. They will just put like inflammation in every answer choice and then like sparing of this or narrowing of this, stuff like that. So being able to like look through and be able to recognize pathology, really big. So again, this one is burgers. Let's go through all of them. So A, granulomatosis inflammation with narrowing of the vessel lumen. That one is supposed to be sort of indicating of Takayasu, because when you have the narrowing of the vessel lumen, right, due to granulomatosis inflammation, that's what's going to lead to the pulseless disease, right? Because it's mainly affecting your tibial, tibial and brachial, of the arteries, and that's why you have the pulseless disease, right? Like why you can't feel the brachial and radial, not tibial. Wow, I'm okay, really, brain's going off right now. That's why you're having the pulseless disease, because you can't feel the pulse, right? So that's granulomatosis inflammation narrowing of the vessel lumen. That is Takayasu, right? Takayasu doesn't present like the question vignette. C, that should have told you that's atherosclerosis, so that should have been immediately out for you guys, right? Atherosclerosis would have like they'd be hypertensive most of the time, so this is obviously not at the hypertensive range just yet. We also have D is something that's DVT. That's one that I just put in there. That one should have immediately been thrown out. You did not talk about any clots made from red blood cells. When you get to DVT in the pulmonary unit, this is how they would word a DVT: intraluminal fibrin clot, predominantly composed of red blood cells. But that should have been immediately thrown out because you never talked about a clot with red blood cells in your cardiac pathology lectures. Next, you have your transmural inflammation with fibrinoid necrosis of the vessel wall. So which one did I say does not have granulomas? Which vasculotype, if we remember?
Is it the microscopic?
Okay, right, that's for the small vessels. Yes, perfect. What about your medium vessels? Sorry, I should have been more specific, but you are right. It is for, yes. PAN, perfect. People message me. So perfect. Polyarthritis nodosa, that is E. So transmural inflammation with fibrinoid necrosis of the vessel wall, that is your polyarthritis nodosa. So yeah, you wouldn't, this presentation doesn't match. I mean, in polyarthritis nodosa, you do have skin ulcerations. So, you know, where they talk about ulceration here, you know, that could make you think of it. But again, he's a man, he's a smoker. That should immediately make you think of burgers. Another thing is too with polyarthritis nodosa, again, right, that one needs renal involvement. Okay, so you need to have hypertension. You're like, you know, if your renals are messed up, you're gonna have to be hypertensive. Okay, also he had Raynaud phenomenon, so polyarthritis nodosa is not associated with Raynaud's, right? That's more your Takayasu and your Berger's disease. Keep that in mind. Good job, guys. All right, let's try this one out. Okay, I could see from the chat that this is throwing you guys off. So okay. So we do have someone who did choose D. So it is a aortic dissection. Let's work this through. So yeah, this is also was like a little bit of a tricky one. Just because one of them does, like, they look like similar presentations, but there is something here that should show you guys why it's not the other one. So let's work through this. Okay, so we have a 55-year-old man, 30 minutes after sudden onset of severe migrated anterior chest pain, right? Shortness of breath and sweating at rest, okay? Immediately when you read something like that, I meant to write E. D and well, I guess F now. Should be like what you should think. You should think of aortic dissection or myocardial infarction, right? So right now, I wanted you guys to sort of narrow down on that, but I understand why you guys chose the other ones too. So we have hypertension, hypercholesteremia, type 2 diabetes mellitus, our usual presentation one for any of either aortic dissection or MI. So we're not anything booted out now. Medications, they always throw that in there, especially if they want to make a farm association, but not important here. He is a smoker, again, makes his, it's a risk factor, right? Pulse is 110, the blood pressure is very high, right? Well, high, not hypertensive emergency high, but high. Oxygen sat. Cardiac exam, okay? So we have a 3 out of 6 high-pitched blowing diastolic murmur, right? Lungs are cleared auscultation. Femoral pulses are decreased bilaterally. ECG, this is what really should have helped you guys out, figure out it's not F, but it's D. ECG only shows sinus tachycardia and left ventricular hypertrophy. What would we see on an ECG for an MI? Right, it could be either be a STEMI or a non-STEMI, but mainly for MIs, we really are more concerned with STEMIs, right? If someone has an MI, they're not going to be seeing sinus tachycardia, right? You could have left ventricular hypertrophy, like a person who has an MI could have left ventricular hypertrophy, but again, like an ECG would show a STEMI or something like that for an MI. The ECG here finding is really what sort of should make you guys be like, okay, can't be an MI. Even though it is 30 minutes, they would probably add like cardiac biomarkers increased or something like that, like to make you think MI. So it is an aortic dissection. So remember, it's severe pain typically in the retrosternal chest area, so the anterior chest, right? If it's in the anterior chest, again, that tells you more that it's the ascending aorta is involved. If they described it more in the back, that would be more a descending aorta. that's involved. So that would be a great DeBakey or Stanford classification kind of question that they could put in there, you know. He has elevated blood pressure. What else is here? But yeah, so like technically, like just the symptoms and the ECG should have sort of made you lean towards D just by that, right? The ECG just helps you cancel out F. If we talk about corbovinum, so what is corbovinum? Does anyone tell me what core is? Because I know we didn't talk about it yet. Or did we? I don't remember talking about it.
Is that the pulmonary heart issue? Can't remember the name.
Okay, right heart failure, I'm getting right ventricle heart, perfect. Okay, so it's called like a cow's heart, right? So it's usually you have like just like hypertrophy of the left ventricle because of volume overload. It goes back into the pulmonary system and then it goes into the right side, and then that you can get right ventricular hypertrophy, right? So that one, you wouldn't have sudden onset of severe migrating anterior chest pain. Okay, like that would be more of like a, if they were to ask something about corbovinum, that would more be like if they were to, they would show you an image and be like, oh, like, what is this? Or they would ask like, oh, like, the pathogenesis behind it. So knowing like, yeah, pulmonary systems involved, because of left ventricular hypertrophy, the blood is getting backed up, stuff like that. But nothing here is really showing corbovinum, but you know, we didn't really go over that, so I understand. What's next? Takayasu. Yeah, you need the, well, let me see for Takayasu. Cardiac exam. So with Takayasu, like, sorry, my brain is like officially going out. With this, you don't really have the pulseless disease or the Raynaud's or anything like that here. Also with Takayasu, right, we want less than 50. Usually it's a female. Okay, so that's another thing to really look for. I know like that's like, oh, okay, like yeah, it could be like that, but it could also be a male. It's like, you know, but they would have to give you more like someone who has like chest pain, like angina, you know, like this is 30 minutes. It's not going to be just normal angina, you know. Vision impairment of some kind would be important. But yeah, Takayasu isn't a good one. Papillary muscle rupture, again, that one would be if you have a papillary muscle rupture, again, the blood is going to go backwards again, but you're not really going, you could have syncope with that one, but you wouldn't have, again, the 30 minutes after the sudden onset of severe migrating anterior chest pain. Whenever you read that, I want you to think MI or aortic dissection. That's really the big one here. Does that sort of help, guys, with this one? I know it was a tricky question. So. Okay. So let's try this one out. 3 more minutes. Okay, I'm gonna go see if my dad needs me, but hopefully we're gonna be able to work these through. So I'll be back. I'll give you guys like a minute or so. Okay, I am back. We can stay until I'm done with my questions. Okay, so I see some of these are throwing you guys off. So let's go through this one again. So this one, oh, okay, I remember this question. Yeah, so it is a little tricky because I did mention like other things, but they could word it like this again. So let's work through this. One of you guys did get the answer. I don't know if you want to, so it is D, it is sudden cardiac death. So whoever chose D, if you want to say what here did you think of? What do you think this patient has?
I was thinking of, was it hypertrophic cardiomyopathy?
Perfect, right. HOCM, hypertrophic
Yeah.
obstructive cardiomyopathy. Beautiful job. Yes. So we have a 16-year-old boy. Like they did at like most of the time they're gonna tell you like like they just had like they passed out while being like working out or something like that. But here they didn't. So this is where like like I do tell you like pertinently what they will, but sometimes they don't have to. So what is going to make you think of HOCM in this case? You have a 16-year-old boy, vital signs are within normal limits, but we see that he has a murmur. And the murmur decreases in intensity on rapid squatting and increases in intensity when he performs the Valsalva maneuver. So do we know what the Valsalva maneuver is? They did teach us this in term 1, I believe. Okay. So the Valsalva maneuver is something that like when you hold your breath, and so this is why you want to think about this, because the Valsalva maneuver, guess who does it all the time? Athletes, especially when they're working out, right? When they're going to work out, when you're or like even if anyone, like when you go to the gym or anything like that and you want to squat, sometimes you accidentally hold your breath, right? And we're always telling ourselves you need to breathe when you're doing a workout. Why? Because we want to make sure that our heart is going to be beating. So when you hold your breath, that will constrict your heart because of your pulmonary system, and blood won't go as effectively into your heart. So that's going to slow your heart down, right? So here it's telling you it's increasing in intensity when it performs the Valsalva maneuver. That's a huge thing that tends to be, that's sort of trying to tell you that, okay, he has something wrong with his heart. The Valsalva maneuver is when he's working out. So immediately you should probably try and think of HOCM. So the murmurs and like those maneuvers aren't going to be as like important for this term, but they are going to be heavily tested in term 5. So also I thought this would be a great thing to go over a little bit, but the Valsalva maneuver, it's really highly associated with athletes because they always are doing it because you accidentally hold your breath a lot when you're working out. And then so if it increases in intensity when someone performs the Valsalva maneuver, you want to think HOCM, especially if it's happening to a 16-year-old boy. Okay, but on your exam, hopefully they did give a very vague one where they didn't mention the patient like have passed out or anything like that. But just trying to recognize anything that possibly increases any pressure. Can you please explain the relationship with the murmur, like the Valsalva one, or the murmur decreases in intensity on rapid squatting to HOCM? Yeah, sure. So there is a image somewhere that I remember in my notes. Hold on, let me see if I could find it because I feel like maybe I'm not explaining it great. Give me 1 second. I have it somewhere on my iPad. Where is it? Mom, I'm in presentation. Okay, hold on, I'm just gonna try and email myself through my iPad this image for you guys. Come on. Sorry, it's just like my phone. Hold on, let me see. I'm pretty sure I got this from Google. So let me see what happens if I see. Can you guys see my screen or no? What do you guys see right now?
Your PowerPoint.
Okay, so you do see the PowerPoint. Okay, good. So let's see. Let's go through any of these images. Got it from somewhere on Google. Oh, this is it. Okay. No, no, I don't want to mess with the chat. Open. Oh, I was hoping to make this bigger. Okay, that's great. Okay, so here we have so when you have the Valsalva maneuver, right? So you guys could, if you want, this would be great for term 5. I don't know if you want to screenshot it or something. Term 5, you need to know this. It's also in your first aid book, I believe. But again, just to sort of understand. So the Valsalva maneuver is when basically when you're holding your breath while you're trying to usually it's seen in exercise. So when you hold your breath or when you cut off any kind of air going into your body as the heart is trying to pump out blood, because you're going to have this constriction from your pulmonary system, right? Because now you're holding your breath, your lungs are filled with air. Now you're pushing on your heart. You're going to have decreased blood going to the left ventricle, essentially going to the right atrium, right? You're going to have decreased blood going to the heart. So eventually you're going to have decreased blood going to the right, to the left ventricle. When you have HOCM, right, it's the interventricular septum that is larger, or like it's obstructive, right, to the left ventricular tract. So when you have less blood returning to the left ventricle, you're going to have an increased murmur sound. So it's not a HOCM itself. So a murmur is just turbulent blood flow, right? Let's get that out of the way first. So when you have the interventricular septum cutting off blood, the blood from leaving the left ventricle out, if you think about it, you have less blood returning. So the blood isn't you don't have as much blood to push through the tract. So if you don't have as much blood, you still have the turbulent blood flow, but the left ventricle isn't filling up as much. The heart is able to contract more. And if you listen, you're actually going to be able to hear that murmur better as a result, because you have less blood in the left ventricle compared to when you're squatting, right? You're having increased blood returning to the left ventricle. Okay, so as a result, you have more blood in the chamber. So in HOCM, you're not going to squeeze out as much, right? Because now there's so much, now it's really disturbing your contractility, because now you have so much blood in there that it's only a little bit is going to go through. You're not going to have as high of a murmur. Okay, I got from someone, yes, that makes sense, of course, anytime. Does that make sense to everyone else too? So they could bring up the Valsalva maneuver or squatting. Most of the time, they're just going to probably tell you syncope, but there was a question on the exam where they said, like, they just brought up the 16-year-old boy and that he was having some kind of issues at his game or something like that. But they didn't bring up that he had passed out or anything like that. So at first you're like, huh? And then it was like, oh, what's the main thing associated with this? That's what I was trying to go with the questions. But yeah, if you guys like that, image, I can paste it into the question slide afterwards, so you guys can just have it there too. So I'll keep that up right now. But if that's good with you guys, we can move on. Okay, I think most of you got, all of you got this actually. Yeah, all of you got it. So let's just start. So someone tell me, what does he have? Right, HOCM, hypertrophic obstructive cardiomyopathy, right? What gave it away? 16-year-old boy, he collapsed while playing basketball. So he collapsed while doing some strenuous exercise, right? It's usually genetic. So usually there is a family history, but sometimes it could just randomly happen. So again, this child has HOCM. What else is here? Family agrees to an autopsy, right? So now we're gonna ask, it's basically asking, what is HOCM, right? What is hyperobstructive cardiomyopathy? And that is the interventricular septal hypertrophy, right? Big thing to know, it's the interventricular septal. No one fell for A, right? I was like, oh, let me put septum in there, you know? What is A? Anyone know what A is? We didn't go over it because we didn't have time, but
Patent foraminal valley. I don't know.
oh, okay, close. It's an ASD. So perfect. Atrial septal defect, right? Embolus in the pulmonary artery. It would cause stuff like shortness of breath. So obviously it's not going to be embolus in the pulmonary artery. Cardiac myxoid tumor. Again, that one, it wouldn't happen in a 16-year-old. Like that's really rare to happen in a 16. It's usually like in your older age individuals. But again, that would more be like, it's a tumor, so you more have like weight loss, shortness of breath, even congestive heart failure with, because it's a tumor that's blocking out the left ventricular tract. So stuff like that. Eventually your heart would start to fail with those kinds of things, unfortunately. Postductal narrowing of the aorta is a fancy way of saying coarctation of the aorta, right? That's very rare to like even give you sudden cardiac death, and these symptoms wouldn't really associate with coarctation of the aorta. I think you guys are going where I'm going with this. For time's sake, if you guys want me to explain any of these other answer choices, why it wasn't the answer choice or what they are, I can like leave an explanation, but for time's sake, I'm going to move on. You all got G, so I feel like I don't have to explain this question that much. Good job, guys. All right, let's try this one. All right, you guys are killing it. You all got the right answer. It is C, right? We have another HOCM. I'm just throwing all these again. This is like really this is what they really focused on in terms of cardiomyopathy. And then you have the diabetes one, but hypertrophic was like the one they were really obsessed with. So you have a 27-year-old woman, right, on the older age, but she's still a young adult technically. So like, you know, 27 is not old, guys. I'm almost there. So, so 1 year history of progressive shortness of breath, right? But now she's having issues with exercise, right? So again, she's unable to jog for more than 10 minutes. Why? Because in hypertrophic cardiomyopathy, when you're doing exercise, blood needs to be pumped out of your heart, right? We need constant blood flow coming from the heart. So if you're having exercise, you need increased cardiac output. But with people who have this, right, you have the interventricular septum blocking that outflow. You're not going to have as much blood pumped out, and that's why she's having the shortness of breath, because she's experiencing like ischemia and all of that good stuff. You also have the murmur here. You didn't need this, but again, that sort of just has to go with that image again. I walked through it, so hopefully that makes sense. But yes, it is a myosin heavy chain defect, right? B is which disorder? Marfan's, perfect. Fibrillin 1 defect is Marfan's. So that would be more like if I was describing an aortic dissection or even an aneurysm, like an aortic aneurysm, stuff like that would be more for Marfan's. These other ones, dystrophin is Duchenne. Yeah, Duchenne muscular dystrophy, again, not important. All these other ones weren't really important. I just put them there because I just put them there. So good job, guys. It is C. All right, let's give this one a shot. All right, you guys are killing it again. It is E. I thought this one would be one of the harder questions, but no, you guys are too smart. You guys all got this. It is E. It is increased left ventricular end-diastolic volume. What do they have? What is this vignette describing? Okay.
Eccentric or dilated.
Perfect, exactly. Dilated cardiomyopathy. So yeah, eccentric hypertrophy. Good, you're already making those connections. I'm so glad. So we have, right, so the duplication of sarcomeres in series, right, big thing. But another thing is, even if you were a little confused about it being, doesn't it also involve? Yeah, so this is where, good point, and this is exactly why I thought this would be a little confusing, okay? Okay, so now we know it's dilated just because of we have the eccentric, we have the hypertrophy of the left ventricular wall and enlargement of the left ventricular chamber. Now, B, I agree, would have been is confusing because you do see some decrease in left ventricular contractility, right, in dilated cardiomyopathy. If we walk through the pathogenesis, right, you will have some kind of decrease. But what this is asking, this is why I'm saying, like, on your guys' exam, be very careful what the question is asking. Which of the following is the most likely underlying cause of these findings? Okay. The whole thing is with this is that you end up, when you start to have the how do I explain? So the pathogenesis behind it, right, is you're going to have increased end diastolic volume due to some kind of causative factor, right? Like most of the time it randomly happens, but you know, you can have the alcoholism or anything like that sort of cause this. Sorry, alcohol use disorder, that's what we're calling it now. And then that could cause the increased left ventricular end diastolic. That increase in the left ventricular end diastolic volume presets to all of the findings, right? It starts off the entire pathomechanism behind the dilated cardiomyopathy. B, it does happen like during the thing, but it's not what presets all of it. It's usually the decreased left ventricular contractility usually happens due to the cardiac remodeling, but it doesn't cause the eccentric hypertrophy itself. Okay, that's usually caused as a result after we have the increased left ventricular end diastolic volume. Okay, so this one was specifically asking for you guys to focus on the fact of that we do have dilated cardiomyopathy, and microscopic examination basically shows eccentric hypertrophy, right? What caused the eccentric hypertrophy is what this is asking, and it's because of E. B does happen in the pathomechanism of dilated cardiomyopathy, but E is really what sets everything off. You know, it's like the starting point, and then eventually it all goes down. Does that make sense to everyone? Okay. getting a few yeses. This was meant to be confusing because B is a good technically, but it's not answering the question, you know, and like this is what SU is going to do. They're going to ask like based off of this. So I know you know all about dilated cardiomyopathy. Focus on what they're giving you and answer the question. That's what I was trying to really get through with this question. So it is E. Good job. If you guys are still confused, let me know. Obviously, feel free to message me on Facebook. Let's try this one out. Okay, a couple of you have messaged me. I'll give you guys like 5 more seconds just because it is 1:50. I don't want to piss my dad off for taking so long. Okay, so let's walk through this one. So we didn't actually talk about this today because, well, it was in my slides, but then, you know, the whole thing happened. But I knew I had questions on it, which is why I didn't freak out. So we can talk about this now. Right, so the answer is it is A, acute rheumatic fever. So let's talk this through. We have a 14-year-old boy, right? He has severe right knee joint pain and swelling. He also has 5 days ago, he had swelling and pain in his left ankle joint. He reports having a sore throat 3 weeks ago. I would highlight, if I was on the exam right now, you know, you have the highlighting feature. I would have highlighted all the stuff I brought up, but especially this part, the sore throat 3 weeks ago. Another thing, he clearly has a fever now though. Painless 3 to 4 millimeter nodules over the elbow. Okay, do we know what those nodules are? Well, so if it is acute rheumatic fever, what am I checking off of? What is the criteria called? Jones criteria, perfect. So here, let's look at let's go over what criteria we need, right? So we need arthritis of some kind. That's a major criteria, right? Arthritis. Here we have arthritis specifically in the severe right knee joint pain, but he also had swelling and pain in his left ankle joint. So here we had it in the right knee, now we have it in the left ankle. That is arthritis, specifically, sorry, it's migratory polyarthritis, right? That's a huge one. That basically means you have arthritis in one spot, now next week you have arthritis in a different spot, right? Like it's just migrating all over the place. So that's a huge thing. When you start reading something like that, you might want to think, okay, migratory polyarthritis, he's young, right? Okay. Subcutaneous nodules, right? We have them over here, the 3 to 4 painless nodules. They're usually painless, right? What else we got? This isn't really that important. Okay, this is where I thought maybe it throws you guys off. No organisms are identified on Gram stain. Does anyone want to take a shot? Why? Because I told you it's acute rheumatic fever, right? And what is usually the causative factor of acute rheumatic fever? Here's our microbiome involvement.
Staph aureus.
Okay, right. Well, yeah, strep. So strep pyogenes. Sometimes, but no, you're all good. So it's group A strep, and usually that's gram positive, right? So you're like, okay, why isn't it being identified on Gram stain? This is where they can catch you with this, because when did he have the infection? How long ago? Good. He had the infection 3 weeks ago, right? Sore throat 3 weeks ago. Are we going to see anything on Graham Stain when we had the sore throat 3 weeks ago? He recovered from it, right? So we're not going to see anything on Graham Stain at that point. If they said, oh, like he now has a sore throat and then they did a Graham Stain, yeah, they would show it. Instead, what could you use to confirm that he recently had an infection? What could I added in here to tell you he had strep? ASO, perfect, exactly. You could use the, oh gosh, what does ASO stand for? Anti-streptolysin, oh, I don't think that stands for anything, but yeah, perfect, exactly, right? So don't get thrown off by no organisms are identified on Graham Stain. Of course, they're not going to be identified. He had the sore throat 3 weeks ago, but they bring up antibodies. He should have anti-streptolysin O, right? So this is acute rheumatic fever. Now, you guys learn about rheumatic heart disease, right? So they're going to give you someone much older, right, with rheumatic, like usually valvular manifestations, right? Because that's how rheumatic heart disease presents itself. But they're going to tell you, like, you know, like they've had this migratory polyarthritis. They fit the Jones criteria, and they're having rheumatic heart disease as a result of it. Yeah, so this is acute rheumatic fever. So they did have something like this on the exam where they were implying rheumatic heart disease, but they wanted you to figure out it was acute rheumatic fever to begin with. And they do care that you guys do know it is the group A Streptococcus pyogenes. Sorry, my brain is like done for the day, but we're going through it. We're going to finish these questions. Does this all make sense to everyone? Okay, I'm getting yeses in the chat. That's good. Okay. Let's try this one out. Okay. Oh, you're welcome, by the way. Someone wrote thank you. So let me see. Okay, so one of you got it, but I understand this one is a little bit confusing because, you know, like I've been bringing up like young children like the entire time we've been talking, right? So this is like, it's hard to sometimes group them together, but let's go over this. What do we think they have? Or what are you thinking that this question is asking about? What disease?
It's infective endocarditis.
Okay, I can see how you think it's infective endocarditis, but it's not infective endocarditis. But you're on the right track. It is an infection, so good job.
Is it rheumatic fever also?
Rheumatic fever or heart disease, yeah.
Perfect. It is rheumatic fever, right? Because we have a 14-year-old girl, 1 week history of malaise, okay, whatever, chest pain. 3 weeks ago, she had a sore throat that resolved without treatment. The minute that they bring up any kind of sore throat, you know, be like, okay, 14-year-old sore throat. Okay, let me think about this. Several subcutaneous nodules, okay, Jones criteria, chest off. New onset early systolic murmur. So usually this happens at a later like age. Usually they start to have heart problems, but this one's starting early. So now we have an endomesiobiopsy, whatever, fancy word, to show which of the following. Now, this I know is a little confusing because I don't know if in your exam, in your lecture notes, if they described what these looked like, but they definitely did it to us on the exam. Because I think they describe it in the, like when they're speaking, but they didn't describe it in the lecture slides. But again, I don't remember. I just remember getting something like this. Does anyone know what B is describing? Okay, so B is describing a, so in rheumatic heart fever, you have the Achoff bodies and the Nitschke bodies. Cells. I don't know if I'm saying that right. But so B is describing the Achoff bodies. Okay. Fibrinoid necrosis with histiocytic infiltrate. Now I know we brought up fibrinoid necrosis for a previous pathology for polyarthritis nodosa. But this one has histiocytic infiltrate. That is an Achoff body that's usually found in the heart, the myocardium, because of rheumatic fever. It's inflammation. So that's why she's having this heart pathology, the murmur, because her heart is becoming affected. And this is due to the Achoff bodies bringing in inflammatory cells into the myocardium. And this is what the fibrinoid necrosis is. It's just trying to tell you it's an Achoff body. If they want to describe a Nitschke bodies, I think it's like the same description, but I think it's also, it says something like mononuclear or something like that. You have to correct me. But on the exam, they were specifically focused on Achoff bodies. They actually provided an image, pointed to an Achoff body, and was like, oh, like, what is this? And they didn't write Achoff body as an example. They've had like these descriptive words. I figured that one out by canceling out everything else. I'm going to be honest. I didn't know how the description was until until I figured out everything. You know how you learn stuff on the exam? I learned something that time. So A, right? Let's go through each one. A, what is A? What is A describing? MI, perfect. Coagulative necrosis with neutrophilic infiltrate, right? MI, within 0 to 24 hours, right? Or 6 to 12 hours for based on the slides. C is amyloidosis. So that would be like restrictive cardiomyopathy. Perfect. You guys are writing amyloid in chat. Great job. So that would be restrictive cardiomyopathy, right? And that's not really associated with rheumatic fever. So myocardial infiltration with eosinophilic proteins. That's a kind of endocarditis. I think we're supposed to talk about, I think this is Loeffler endocarditis. I have to double check. But that is also a restrictive cardiomyopathy, again, not associated with rheumatic fever, right? So this B is an Achoff body associated with rheumatic fever. That's why it's B. E is, so a lot of you chose E, and I see why, because again, young, a child, right? But not a, no symptoms of like, what's it called? Nothing here to tell you that it's like exercise induced, right? So E is actually describing a HOCM, right? Fibrosis with myofibril disarray. That is describing the histopathology behind, or not pathology, but the histology behind HOCM. So, yeah. Like that on the exam, trust me, like I have to go through each one of these being like, why can't it be this one, and try to like really force my brain to remember the histo. It was like difficult, but if you don't, there. Yes, hypereosinophilia for Loeffler's. You are right. Perfect. It's yeah, you have infiltration of eosinophils and Loeffler's, and that's what makes it a restrictive cardiomyopathy. So yeah, they would probably bring up something like either hypereosinophil or to tell you increased IgE, stuff like that to sort of give you away. Associated with like diastolic heart failure, I believe. So yeah. Okay, so now you know what Achoff bodies is described as. So, you know, advantage, but they might describe it in Nitschke body, which is like I think a mononuclear or something like that. But just try and go through each one and cancel, because that's what I have to do. So learn as you take the exam, it's fun. Yes, okay, let me see how many more questions we have. See, I think. Okay, so I'm actually going to skip 3 questions because like I'm gonna upload this so you guys can do it on your, but I feel like these are just sort of like, you know, like just don't look at it. Okay, I want to get through the congenital ones. I feel like those you can, when you read the question, you can figure out why micro was more relevant for the heart implication compared to other ones. So I don't, because I do have to, yeah, my dad's gonna get this off. Okay, so let's go through these. There's 2 of these, so we're almost done. And then if you guys are confused about the questions at any point, you know, feel free to message me. I don't celebrate Easter this week, so I'm free pretty much during break. Anytime, Brittany. So let's try this one out. Oh no, where'd the chat go? Just happened. All right, I think this one stumped most of you guys, and since I'm running with time, let's just go over this one. Okay, so let's walk through this one here. So we have a 16-year-old boy, 6-month history of progressive fatigue, worsening shortness of breath. He's always been tired more easily. Immigrated child, oxygen saturation 96%, right? Radial pulses are bounding. You have a mild bluish discoloration and bulbous enlargement of the distal toes. Okay, so this one, it is tricky. We didn't go over these, you know, and when you approach your congenital heart defect lectures, you know, always group them out between cyanotic and acyanotic. It'll make life so much easier, right? And then try and work through the symptoms that way. So let's go over this one. So the answer is C, persistent blood flow between the pulmonary artery and descending aorta. What is that describing? Okay, perfect. Patent ductus arteriosus. Beautiful job, guys. So, so basically, a patent ductus arteriosus, right? If we think of it, that just means that the ductus arteriosus didn't close. That's why it's called patent, right? And usually that allows the blood to be shunted properly during fetal development. But you know, when the fetus is born, the baby is born, right? We want that to close off, right? Because it doesn't allow for blood to flow from the descending aorta to the pulmonary. We would have a left to right shunt because it didn't close, right? So in a large PDA, usually people with PDAs, like not too affected, but really big ones can cause, what ends up happening is because you're having the blood shunt, the left to right shunt, you're gonna end up having, when you have the left to right shunt happening, right? So now you're having an enormous amount of blood coming from the left ventricle and swiping into the right ventricle, right? So now you're gonna have volume overload of the right ventricle. And then that's gonna get shunted into your lungs, right? Because when it goes from the right side, it goes into the lungs. And then that could cause a lot of pulmonary pressure within the pulmonary circulation, right? So you're gonna have pulmonary hypertension. And eventually, if in large PDAs, if this isn't like fixed or closed off, you're gonna end up having the pulmonary system become overwhelmed. And you could eventually get something called the Eisenmenger syndrome, I think it is. And then that could, that would show you as now the patient who has been fine most of their life, now out of nowhere, they're having clubbing of the fingers, cyanosis, bluish discoloration, right? That's telling you that, 16 years old, he's been living fine. Usually if it's a cyanotic heart defect at a young age, you're going to see these symptoms. But at 16-year-old, that just sort of tell you, okay, like clearly they were fine. Now they're not. This is probably an Eisenmenger syndrome, right? You had the reversal of the shunt, and now you're having a cyanosis in the patient, and that should tell you PDA is one of those that can have that Eisenmenger syndrome occur, and that's why we're going with C. Some of you chose E, so let's walk through E. E is coarctation of the aorta, right? Abnormal narrowing of the aorta at the aortic isthmus, basically coarctation of the aorta. You would have bounding pulses, and you could have cyanosis in the feet or just in general, but this mainly happens in babies, not really in older children. Because if you think about it, something that's acyanotic, like we want to fix it. And like coarctation of the aorta, if it's really causing problems, that would be more something you want to fix at a younger age. You could have a older child, a postductal coarctation of aorta. Or you could, yes, you could have one, but typically you wouldn't have cyanotic features, I believe. You could have the pulses not, you could have where the pulses, you wouldn't feel them, but not really any cyanosis. Typically, yeah, so I could see how you guys would choose E, but usually this one's really trying to show off Eisenmenger syndrome. Like the boy was fine, now out of nowhere, he's having all of these symptoms, cyanosis, radial pulses bounding, stuff like that. That's really trying to tell you guys Eisenmenger syndrome, which is usually associated highly with a large PDA. It could be, Eisenmenger is anytime you have a reversal of a shunt, but most of the time it's very highly associated with a large PDA. So that was like what I was trying to go with this question. Okay, if there's no more questions, I'm just gonna move on so we can do this last one. And then obviously at any point, if you guys are doing questions or have any questions whatsoever, feel free to message me on Facebook. I'll be around. Let's try this one. Okay, so I have a question in the chat. So, if you have, so it can be any shunt. So if you have a left to right shunt, right, that's usually considered acyanotic because you're having blood that is already oxygenated, just being shunted to the right ventricle. We don't really have any issues. Eisenmenger is when the pulmonary system gets so overwhelmed after that left to right shunt. Again, it depends on how big the shunt was to begin with. That's why I said large PDA, not necessarily small ones, because small ones can go like undiagnosed for years because they're not going to cause a reversal of the shunt. But anytime you have a large anytime you have a large shunt of a left to right, eventually your pulmonary system is going to get overwhelmed. You're going to have pulmonary hypertension. That's going to reverse the shunt. So now you're going to have right to left shunt. That's what Eisenmenger syndrome is when you have a right to left shunt. And at that point, now you're having deoxygenated blood entering the left side, right? And the left side always pumps blood out into our system. So now you're gonna have more deoxygenated blood being pumped out into the system. That's the issue. So Eisenmenger can be associated with anything, with any shunts, but typically it's more like PDAs if it's large enough. Basically, if they describe anything if they wanted to ask about Eisenmenger, they would have to put more like in the vignette, like someone older and out of nowhere, they're now like, you know, experiencing symptoms of cyanosis. That's what they would really be going with. It's not highly associated with one, but it's really more dependent on the entire question. And really PDAs, like large ones, are highly associated with Eisenmenger. I believe that's where they introduced Eisenmenger in your guys' notes. So I hope that makes sense. Anytime. Okay, so not many of you have answered this one. It's okay. I mean, I know we didn't go over it, so I don't blame you. And honestly, congenital heart, like I think it was like 3-4 questions, but obviously I don't know how they're gonna do it for you guys. So, you know, study your slides, but I'm just saying, if you feel a little uncomfortable, for me, it wasn't worth that much. So for this one, right, we have a sudden weakness of her right arm and leg that started 3 hours ago. Oh, 35-year-old woman, right? She was previously healthy, so, you know, no issues, but suddenly she has sudden weakness of her right arm and leg that started 3 hours ago. She returned from a business trip from Europe 3 days ago. What else we have? She's on oral contraceptives, deep tendon reflexes are 4+ on the right. Babinski sign is present on the right. Should we be seeing Babinski sign in anyone older than a neonate? No, right? No, we do not want that. So that something's telling us something severely wrong with the patient, right? Left lower leg is swollen, erythematous, and tender to palpation. Further evaluation, okay. So, does anyone recognize what, I know it doesn't seem like a keyword, but you guys did learn the association with DVT and like just paradoxical embolus, right? In your I remember it was in one of your slides, the paradoxical embolus, right? This is what this is trying to go for. The return from a business trip from Europe 3 days ago. Anytime it's where someone is immobilized, is the word they like to use, for a long time, you have the increased chance of forming a DVT, which could eventually embolize, as you know, that's what a DVT is. And then eventually, if you have certain congenital heart issues, you know, that could lead to a paradoxical embolus, where it gets dislodged from the heart and goes like in other parts of the body. Usually the risk is cerebral, and that's what paradoxical really is implicating. But this here with the whole business trip, it was trying to tell you, like, you know, she was on a plane from a long time ago. We're assuming this is to America, so, you know, I don't, like a plane to Europe is like 6 hours minimum, I would think. So yeah, basically she was immobilized, right? So she had increased risk factors for a DVT, so that could lead to clots being formed. She's also, she's a smoker, and she's also an oral contraceptive, which you guys should know should be create clots. You guys are gonna learn that later when you get to that unit. So again, she's presenting with she has sudden weakness of her right arm and leg, right? So now she's presenting with a left, with a right-sided stroke, right? So she has sorry. She has weakness on the right side of the body. So you know that it's a stroke of some kind. I believe it's actually a left-sided stroke. It's on the right side of the body. Yeah, sorry, my neuro is a little weak right now. But basically, you know, she's having cerebral symptoms, right? Along with the left lower leg is swollen, erythematous, and tender. That's telling you that she has a DVT, because DVT, you're gonna have a swollen leg. It's unilateral, right? So one leg is swollen, and then she's having neurological symptoms. So you guys should think, okay, DVT, neurological symptoms, most likely a paradoxical embolus. And the highly associated heart defect with a paradoxical embolus is usually a patent foramen ovale, because technically a paradoxical embolus can go from any right to left shunt, right? Like if you have Eisenmenger syndrome, but usually if a patient has a patent foramen ovale, it has a really increased chance of going through that instead. It's usually the more like common thing that we see with a paradoxical embolus. So again, that's sort of what this was trying to go, to make sure you guys know that patent foramen ovales are highly associated with paradoxical embolus. And yeah, that's what I was trying to go with this one. Does that sort of help? They will ask a question about a paradoxical embolus on the exam. That's why I sort of brought this one up. And they will ask a question about the Eisenmenger syndrome on the exam. At least they did for us, but like they should, because it's like one of the like bigger things that you are really concerned with congenital heart defects. So yeah. I hope that all made sense. I do have to go now. My dad's probably gonna kill me, but you know, I'm gonna upload everything the minute that I get a chance to, and when the recording's up, I'll upload that too. Again, feel free to message me at any point. You know, I'm pretty much, other than helping my dad, I'm pretty much doing nothing during my break. I feel bad that you guys have an exam literally right after the break. It's not really a break for you guys, but feel free to message me. You guys are gonna kill it. Just make sure when you're on the exam, read the question. Okay, make sure you're answering the question, because sometimes I put multiple answer choices that look good because it fits the symptom of the pathology, but you need to answer the question. So yeah, I hope this was helpful. You guys are telling me it is. I'm glad. Yeah, obviously feel free to message me and I'll upload everything when I get a chance. So I'm gonna just stop recording.